Good afternoon, everyone. Thank you for joining us. My name is Neeti Alapati. Welcome to Doctor in the Group. This is just reviewing our financial disclosures. Most of us don't have much to disclose. I think this is really exciting. After a really tough year and a half, we finally get to be together, talk about some interesting educational topics, just be around other human beings. So I think we have a lot of interesting things to talk about. I wanted to thank Deb Kephart because she really puts in a lot of effort to make this event possible. So it's not easy to coordinate everyone's schedules. I think we're going to start with Dr. Sutphin, giving us a little welcome.
Welcome. I'm going to take this off the top. It's hard enough to hear me when I'm not wearing it. We are here in the auditorium for those of you who are online, and we will be in and out all afternoon. Not to worry if you don't see everybody all the time, because now you can actually watch a little bit of what's happening in the room, courtesy of Dr. Nesmith. I have given this talk every year since we resumed EyeCon back in 2007 or 8, I forget when. Having a long hiatus since Dr. Hunter had been the chairman. So this is basically just a quick overview. I'm not going to talk about COVID impacts. I'm tired of talking about COVID impacts. We just live with them. That's what they are. They're getting fewer, which is a good thing. Today they opened up travel in the United States, Kansas. So you don't have to quarantine when you come home, as long as you stay in the States, which is a positive sign, because before there were still a few states you couldn't go to. What we go through is the people that you're going to probably hear from today. This is our graduating class, Dr. Brass, Dr. Kimple, and Dr. Stefonowicz. Dr. Kimple is our chief resident. This is the rising class, the new class of next year. 22, Dr. Ambrose is the chief resident. Dr. Long and Dr. Nasrazadani are here in the room with us. They're our senior residents. And these are the rising, no longer going to be doing consult residents. Dr. Alapati and Dr. Haghnegahdar is here. I don't know if Dr. Miller is going to be here, but that's the group. And then the interns that are now becoming residents when we hit July, Dr. Kalina, Dr. Craig Wallach, and Dr. Mitchell. Dr. Mitchell was here earlier. I don't see him right now, so maybe they're around in the room. And then we have a surprise this year. At the end of March, we learned about a program that was closing in Ohio, and they had residents that they needed to place. We've been approved for 4 residents for a year or so. So we took the opportunity to bring 2 of them here. Dr. Grogan is going to be in the PGY3, the second year class, and Dr. Sewley is going to be in the senior class. Then we have new interns next year. This was our first full group of interns. Next year will be our second group. Dr. Rachel Chu, her mother was a resident here by the name of Chu. Now I'm blocking. It's okay, it'll come tomorrow. Dr. Jensen, Dr. Karatage, and Dr. Fanningsteele are all joining as an intern. They will be with us for their total of 4 years. This is where our alumni are. We're still waiting for people to move to Utah. I don't know what they don't like about Utah, but sooner or later we'll put a blue spot there too. Just a reminder, we will have an alumni reception at the Academy in person. We don't know where yet. We'll give you the information as we get it. So that's coming up in November. And these are our faculty. There are 13 of us full-time and part-time on faculty here now. I no longer have a full list, Greg, of all of our associate faculty.
No, I was looking for a power connector.
There's one in the background. 32, we have 32 volunteer faculty. We have a number of research projects running right now, a couple of NEI funded, and we have still a very active Lions Club and a very actively publishing faculty. So I thank you all for being here. I look forward to this afternoon, and hopefully we'll have an in-person meeting next year that is more social.
Okay, I just wanted to preface, so this is one of our first year residents, Lori Miller. Her talk is focused on oculoplastics. She was the one exception we made for pre-recording because she's on maternity leave. She just had a baby like 3 or 4 weeks ago. So I'm going to go ahead and start this. I'm going to begin in person.
information on the use of telemedicine and oculoplastics. As we all know, the COVID-19 pandemic has had many effects on the way we practice medicine, the way we interact with our patients, the way we provide care. Specifically, the pandemic has led to an increased use of telemedicine. There have been studies in the past that have looked at integration of telehealth into an oculoplastic practice, but this study aims specifically to look at the best uses of telemedicine and oculoplastics. 395 men and women aged 3 to 95 seen from April to September 2020 with an oculoplastic department at KUI were included. Via chart review, the subjects were categorized based on their age, gender, encounter type, appointment format, and whether the patient presented. The data was then analyzed using chi-square testing and linear regression models. Most patients seen were females over the age of 60. The most common encounter types were new patient and follow-up. There was statistical significance between encounter type and appointment format, with most telehealth visits being either post-ops or follow-ups. Expectedly, there was a significant difference in the number of appointment-related complications in appointment format. Telehealth visits had a higher association with complications, including a delay in appointment time due to connectivity issues from having to resort to a different appointment format. In other words, having to reschedule for a different day in person or resorting to a phone due to issues with the telehealth interface. There was a positive correlation with age and complications. However, this was not found to be statistically significant. There was also no statistically significant difference in no-shows among telehealth versus in-person visits. In conclusion, we determined that telehealth was an effective and safe way to provide care in an oculoplastic practice. It was useful for both post-operative visits and pre-operative evaluation, as well as new patient visits and routine follow-ups. Patients of various ages were able to utilize the technology effectively to attend a telehealth visit with minimal complications. To reduce the frequency of these complications, we believe it may be prudent to implement an interactive tutorial for patients to use prior to their appointment time. Trial during the COVID-19 pandemic at KUI and supported by previous studies, telehealth has proven to be a useful tool for an oculoplastic practice. Further research investigating the outcomes of patients seen via telehealth versus in-person is warranted. Thank you for your time and enjoy the rest of the research symposium.
Any questions? Sir.
Okay, somebody didn't do a lot of telehealth, and you say that there weren't a lot of appointments. Did you account for how often your staff was calling and they didn't answer, or they had is there extra work in there that's not being accounted for? What did you count as a missed appointment?
I'm not sure what she counted, to be honest, but I will tell you, regarding telehealth, it kind of stopped giving us to go back to in person. I felt that, yes, it did make things somewhat easier for the patients who were able to easily do the virtual visit, but a lot of time was spent educating them how to get in the system, because we had to do it technically through our EMR from KU, whereas in the private sector, you might be able to easily just do a Zoom or a Doximity or one of these other programs, which sometimes a little easier. But yes, I think the missed appointments probably were just, when the patient said, I can't do this on the computer or telephone, and we just said we have to just get you to come in. I don't know the exact percentage. But yeah, it becomes a lot of training work. But thankfully, I don't think this is going to be our number one thing. But
it doesn't work for us very well, so
Yeah.
we still have it. Other parts of the hospital, psychiatry and medicine, internal medicine, went way up. So they went from 0 to over 4,000 visits a week, and stayed there. They really have not come back down, particularly the psychological services, psychiatry and social work, those things. So it works in some settings. It doesn't work well for us. Plastics was the one area we thought it might work. Post-op, you don't really have to have a slit lamp exam. We've done some other things to try to make it better, but it's still not a particularly useful tool in ophthalmology.
it sometimes works well for follow-ups to go over testing, imaging, surgical planning, if you want more people involved. But to be honest, I'm kind of over it.
Yeah, I just wondered
The onco, since I do some melanoma work, the radiation oncologist that I work with, the KU really pushed him to do a lot of telehealth, way out of his comfort zone. I don't know how he's supposed to do the digital exam of the prostate, but that he thought he needed to do. But his KU really pushed him. They liked the productivity that he was getting from it. It just seemed interesting as an outsider looking at it.
Yeah, I think we all tried in the beginning, and we tried to make adjustments as glaucoma. We would do kind of hybrid visits where people would, get like their pressure checked outside or do like a, quick test and then head out. But then I think once we realized, as things progressed and we did what was in the best interest of patient care, kind of evolved in the other way. I think definitely it's interesting to see in the pandemic how things did evolve and in our health system. I think a lot of specialties really adapted to the telehealth really well. But I guess each specialty, maybe if people were using more apps for like intraocular photos or something, that would be really helpful. But again, I think the age fact, our patients are typically elderly. That's a big limiting factor on that. But thanks for the question. Moving along, we're going to have one of our third-year residents, Dr. Brass, has an interesting topic for us about fires and phacoemulsification. Dr. Brass is going to be in town, comprehensive up north, so we'll let him go next.
All right, so thanks, Dr. Alapati. Slight title change, the risk of thermal burn, cataract surgery related phacoemulsification, and Dr. White, my primary supervisor. So as we know, modern cataract surgery relies on a phaco handpiece, which is an ultrasonic device to disassemble and emulsify cataract. Extended use of the device has been known historically to lead to corneal burns and subsequent long-term ocular complications, but there are safety measures built into the device to help keep it cool, such as irrigation. However, there are some rare circumstances that can occur outside the eye when phaco ultrasound continues to run without irrigation. An example of this would be progressing during cataract surgery to cortex removal, switching out the hand pieces, but then not changing the setting on the phaco machine. So the purpose is to explore the potential of a phaco handpiece to cause thermal burn injury to a patient outside the eye and determine how protective the drapes may be in that situation. So we used an EyeCon Infinity phacoemulsification machine and handpiece. We also used two types of drapes, the Hendry Shine and the Steri drape. And then we used a pigfoot as the model for human skin. We completed 3 trials to assess the temperature of the phaco tip while comparing the different materials. Pigfoot without a drape, and then each trial was performed twice with and without the silicone sleeve on the tip. And the temperature of the tip and the pigfoot were measured with the thermometer. So the base temperature of the pigfoot was measured at 21.5 degrees Celsius. With no drape, the tip without the sleeve quickly charred the skin in 3 seconds, and the tip with the sleeve created char, but took longer than 3 seconds. The Hendry Shine standard drape tip with and without sleeve did not create char on the pig skin, but did burn a hole through the drape eventually. In the plastic Steri drape, tip with the sleeve was able to burn through the plastic drape and char the skin in 2.7 seconds. The one without the sleeve took less than 1 second to burn through the plastic drape and char the skin. Here's just some photos. It shows the scarring. The charring we had on the pig's foot and the drape, the burn holes. So our results show that there is a theoretical risk of thermal injury to patients if the phaco tip is not handled properly. One trial showed a max temperature of 53.6 degrees Celsius on the body of the phaco device after a short period of time, and temperatures above 51 degrees Celsius can cause immediate destruction of the dermis. The silicone tip was seen to be protective over no tip, but not 100% burn proof, with both drapes having holes in them within them in a few seconds, and plastic drape not being able to prevent skin charring. So only 2 types of drapes were measured. There are numerous other drape types and manufacturers that are using ORs. Because of this, it may not be possible, or it may be possible to ignite a different type of drape, and other drapes may potentially offer more or less protection from thermal injuries. The experimental results would also be more accurate if done with an infrared thermometer. This reduced lag between measurements, but there was difficulties with obtaining this primarily due to cost of purchase. The experiment was not performed in an oxygen-enriched environment for safety reasons, which was the initial goal of the project, because during cataract surgery, sometimes we create like an oxygen tent. So it could be even more dangerous in that scenario. But if proper methodology was figured out and safely perform the experiment, it could be conducted again in the future with oxygen. So in conclusion, our results showed that while phaco handpieces are generally safe, they can cause thermal burns. These burns are more likely to be seen when irrigation is not connected to the handpiece, but the device continues to run. So this is like progressing during cataract surgery, cortex removal, switching out the handpiece, pressing down on the pedal when the setting has not yet been changed at IA. More research is needed to see if the heat generated by the device is enough to ignite a true intraoperative fire in an oxygen-rich environment, but focused efforts on using the silicone tip, irrigation system, and not placing the phaco tip on the patient can prevent these burns from occurring. Thanks to my two medical students, Arya and Fahad from UMKC to help me with it, and Dr. White for coming up with the project, and Local Pig for donating the tissue. Any questions if you have them?
Okay, next up, we have Dr. Haghnegahdar, one of our first-year residents, talking about patient phone calls to residents and accuracy in catching vision-threatening diagnosis. I think this will be really interesting.
I'm Megan. I'm one of the first ophthalmology residents here at KY. My project's on navigating ophthalmology patient phone calls, the resident edition. Special thanks to Dr. White for helping out with this project. And also special thanks to all of our residents for providing all the data for the project. And thanks to Justin Russell for giving us the data collection analysis. So a responsibility to ophthalmology residents on call is answering patient phone calls. That's a nationwide thing. Happens across different specialties as well outside of ophthalmology. Really depending on the complaint made during that patient phone call, the resident has to make the decision whether or not to bring them in to see them in person that night for evaluation. It's typically a difficult decision to make, especially in the early parts of our residency, whenever we're just learning how to examine a patient, learning how to create a broad differential, and just learning how to really navigate. So there's various online guides that have given advice on how to really approach these patient phone calls, but there's really no published data looking at, what comes of these and what comes of the evaluation. There's also really no literature that looks at the most common complaints made by the calls, by the patient on these calls, really what complaints trigger residents to have those patients come in for evaluation, or even the accuracy of those diagnoses. So this would be very helpful information for a new incoming resident. So my first objective was to determine what percentage of resident diagnoses are correct in these evaluations. And then other objectives were to look at the complaints that were associated with the resident bringing in those patients for evaluation in person, determine at what rate we make vision-threatening diagnoses, and to just look at the various characteristics of each of these calls. So we looked at all the patient phone calls from February 2021. My data was provided by 4 different residents, 2 PGY2s, 2 PGY3s. And the chart reviews were completed for each of those patients by looking at the telephone notes created for each call. And we collected all the data and analyzed it through RedCap. So we had a total of 18 calls amongst 4 PGY2 and PGY3 residents. It was pretty evenly divided between both of those years. Looked at the reasons for the calls. So there are 15 specific ocular complaints, then 2 post-operative questions, and then 1 medication insurance question. So of those specific ocular complaints, the majority were people complaining of eye pain, which made up about 60%. Other things were things like vision changes, binocular diplopia. One patient had like eyelid and facial swelling after taking prednisone, kind of an outlier for everything else. Another patient had bleeding from their eyelids, and one had suture coming loose after surgery. So of all those patients, 8 were told to come in for evaluation, which is about 50% of the total. And of those patients who were told to come in, by far the most common complaint was having eye pain. Next was bleeding from the eyelids. We were told the patient who eventually declined coming in for evaluation. And then this patient with eyelid and facial swelling after taking prednisone, they eventually declined as well. Then I was interested in looking at how many of these patients were actually in the post-op window within like a 1-month period. Turned out about 60% were, on average, they're about 5.6 days post-operative, and really kind of ran the gamut in terms of what kind of surgeries they had. 3 head Ahmed tubes placed, 2 head Ahmed tubes, 3 of PKPs, 1 cataract, 1 PPD, various lid procedures as well. And so of those as well, the most common complaint was eye pain. 2 of them had vision change. Another one had bleeding from their eyelids. Another one had a suture come loose, and another one had binocular diplopia. And of all those, in the 30-day post-op window, 5 were asked to come in for evaluation. So that made up about 56% of the total sample. So here are the official diagnoses made by residents during the in-person evaluation. These first 5 that are bolded are the ones from the 30-day post-op period. So one had a post-operative IOP spike, one had pain, one had post-op eyelid bleeding, one had post-op corneal edema, and then that other one that had diplopia who didn't come in. And then the bottom 3 were folks who were not post-op. So one with blepharitis conjunctivitis, one with trichitis, and then the one with the eyelid and facial swelling after prednisone. Of all of those, the one that is designated as a vision correcting diagnosis with a post-operative IOP spike. So it was one diagnosis among the full sample. So 100% of all of the resident evaluations were correct. And the way that we determined that was comparing the resident diagnosis to the attending diagnosis made at the next clinic appointment. So great job, everyone. There really was no urgent cervical. No urgent or surgical or laser that resulted of that
Doesn't
result.
speak to anything else. Doesn't
Ask him to mute.
Can you guys?
employment arrangements, doesn't speak to the ability.
Mute all.
Those are documents that
Okay. Okay, so no surgical or laser procedures came as a result of the resident diagnoses. There are various medical and procedural things that were done, starting IOP lowering agents, epilation of the patient had some trichiasis, and changing some steroid and neuro dosing on a patient with corneal edema. Okay. So in conclusion, residents did a great job, made the correct diagnosis the majority of the time in this sample. Really only one patient had vision threatening diagnosis. About 60% of the calls were from patients who were in a 1-month postoperative period. And of those, about half of them were asked to come in for in-person evaluation. So residents are more likely to have patients come in if they're within that 1-month post-op period and having pain. However, there rarely was any vision threatening pathology identified. A few limitations, definitely more data is needed. So it'd be nice to kind of span this over a longer period of time and get a larger sample size. Also, the data doesn't really reflect some of our extreme situations. So there's been some residents who have been on call and they've received like 20 patient phone calls. That's obviously a different triaging system having to involve your senior residents. So kind of a different picture format there. And again, this isn't really totally reflect our entire patient population. 2 residents couldn't give data just because of pager issues in terms of keeping all those pages, but there's something to work on in the future. So just takeaways from this, residents were doing really well in making this in diagnosing these in-person evaluations. If you're an incoming first year, it's probably just a really good idea to have any patient who is within that 1 month post-op period and having pain, just go ahead and have them come in for evaluation. And it's important for us and for budding surgeons to remember to discuss with our patients just like symptom expectations after surgery, like what's a normal symptom to have versus what is something really serious that we need to call about. It's just a good reminder with this project.
So Megan, I have a question. So the 56% that were asked to come in, why only 56%? Was that excluding like people who couldn't come in? And how do you determine who you're asking to come in and not come in?
Yeah, so like some of them also, the majority were patients who also said, well, I have my 1-day post-ops tomorrow, and I just come to that appointment instead. That was a large majority. Some of them, were patients just saying, no, I don't want to come in. And others were, I guess, just less concerning complaints related. So just went into the residents' decision making whether or not they had to come in.
Did you happen to look at the patients that didn't come in and see if they had any vision threatening?
Yes, no, they didn't. So the one with the binocular phobia, that was just like a surface related thing after their first therapy. That didn't really amount to anything super serious. And the next one was a lady who has like multiple allergies. She thought that prednisone might have caused her symptoms, but in reality, it might have actually been something different. But those are the main 2 ones that.
I think as a general rule to the residents, post-ops first week for sure should basically come in unless they absolutely cannot, which sometimes happens, but pretty much they should always come in. Oh, it says we're having trouble hearing audio coming in. IT, do you see that message? It says they're having trouble hearing audio coming in and out. Oh, it might be muted.
We are.
No, not us, but the response
Oh.
might be muted.
They can unmute themselves.
Can I? Okay.
No, it should be on.
Yes, it's set up that way. I don't know what that means.
Maybe it's under everyone else.
Okay, you wanna-
Yeah, sounds good.
Before we switch, I have a question.
Yes, oh, sorry.
I'm just, like, is there a role for like the telemedicine visit in this setting? Have you used it?
No, well, that's a really good question. I haven't personally used it. I don't know that any of our other residents have used it. Patient phone call.
I actually used to a little bit. The Doximity app has a video dialer, and back when it first came out, it was I was on primary call at that time and found it very useful. I think after we kind of looked into it, the policy on that might be kind of hit or miss, so we stopped using it after that. But if the policy is, if we're allowed to do it, I think that's a great app.
I think a lot of the times patients will upload photos to my chart and we'll look at them that way too. But that only offers so much. It's helpful, but still hard.
I think it
You
would
can
still
project
be-
an eye chart or an AMZ grid so the patient can see. It's very hard to standardize the size, but
Yeah.
it can be done.
Yeah.
It's food
Great
for thought.
idea. Thank you.
Next up, we have Dr. Akhila Alapati going over the benefit of operating on unilateral congenital cataracts between ages 6 and 10.
My topic is exploring the clinical benefit of cataract extraction for unilateral congenital cataracts in patients ages 6 through 10. My name is Akhila Alapati and my mentor is Dr. Stahl. In terms of background information, unilateral congenital cataracts are usually operated on at 6 weeks of age, and bilateral congenital cataracts are usually operated on at 10 weeks of age. However, there's limited evidence in the utility of cataract extraction for late presenting patients with congenital cataracts. And usually in the United States, we catch these patients after they had their first vision screening. In terms of a literature review, again, there's limited research outside. There is one article that I picked up in terms of discussing a delayed presentation, and this was done in India through a large population. And the study mainly looked at the risk factors leading towards a delay and not necessarily the benefits of an outcome of cataract extraction on these patients. And those delays are mostly systemic and demographic features. The purpose of the study is to investigate the clinical benefit of the cataract extraction and to see if there is a visual or functional outcome. The methods that will be used is a retrospective analysis that's conducted at specifically ages 6 through 10. And again, this is usually after the first visual screening that they present. And then the data would be extracted from the Red Cat EMR at Children's Mercy Hospital. It would be de-identified and stored in a safe network. The variables gathered would include age at cataract extraction, type of cataract, because secondary cataracts would be excluded, for example, trauma, the best corrected visual acuity prior to surgery, and then the best corrected visual acuity after surgery for surgical patients, and then a baseline visual acuity for non-surgical patients, and then a visual acuity at their most recent visit. A statistical analysis would be performed on groups who underwent the cataract surgery, so their visual acuity before and after, and then a analysis on patients who didn't undergo, so their visual acuity on their first initial visit and their last. And these two groups would be compared for a significant difference in outcomes. Inclusion criteria would be specifically those operated at Children's Mercy Hospital at either the Kansas City location or the Kansas location. And most of these patients have been operated with Dr. Stahl because she's the primary surgeon who would be taking cataracts out of patients in that institution. The exclusion criteria, like I mentioned, would specifically be secondary cataracts, like for trauma or systemic illnesses. So unfortunately, the data collection is still in process because the MRN list hasn't been provided yet, but the IRB protocol has been approved. What I expect from the data is that around 100 patients would probably be included in the study because we're looking from 2011 to 2021. And from a majority of the clinical suspicion that Dr. Stahl has at this point, that there's not likely a outcome benefit for these patients. And the reason we wanted to look into this is so that we would be able to further guide our discussions with parents to determine whether cataract surgery is best fit for these patients or not.
Next up, we have Dr. Dr. Nesmith, who's coming to us from Wichita, which is a pretty far drive. So we're really happy to have her speak with us regarding macular degeneration, the current and future treatment options.
Hi, good afternoon. As she said, my name is Brooke Nesmith, and I'm a retina specialist in Wichita with Big Retinal Consultant. So I want to thank the organizers of this for inviting me to come and speak. When I was asking one of my partners, actually a couple years ago when I got first invited, what topic I should do, he suggested macular degeneration. I thought, oh, God, that's so boring. I can't do pretty pictures, which I like to do in my talks because in retina, we know we have great pictures. But the more I got to thinking about it, it's so prevalent, especially in our older patient population. And it's really the question you get all day long is, what are the options out there for me treatment-wise and what's coming down the future? So I went on ahead and stuck with the topic. I did want to just touch a little bit so I can get a little bit of my funny pictures in. Just on diagnosis. So as we all know, clinical exam, of course, but OCT has largely supplanted fluorescein angiography. We use that mostly. Some people may still get a baseline fluorescein. I tend not to. And then of course we have OCT-A angiography, which is still finding a place in our clinics. So here's a patient of mine, 20/150, sudden spot in the eye. And so of course you can see there's some subretinal fluid, definite activity there. We did the OCTA, and you can see the obvious devascularization right there. So for those of you, I know everyone's familiar in this room with OCTA, but just to refresh, it's non-invasive modality for looking at blood flow, and it usually uses motion contrast. It's wonderful, and we're still learning how to use it in our clinics, but of course it comes with limitations such as motion artifacts. Patients can't see well or hold still. And then also projection artifacts, where you've got these larger superficial blood vessels that will project onto the deeper layers. And then also because it depends upon motion contrast, you might have some trouble visualizing the slower flow neovascular lesions. Doesn't also show leakage. So how do you tell active CNV from non-active CNV? Again, back to my picture, when I look at this, I always think of a tumbleweed type appearance with the multiple anastomosis and loops. And then in the study in 2017, they were looking at inactive CNV. And here you can see right here, you've got these larger mature vessels with the intervening hollowness. So I like using OCTA in the clinic, but I'm still just sort of learning where it's applicable and where it's helpful and not. Now for treatment options. So dry AMD, we know there's really not much out there. It's just the vitamins. And we based upon AREDS and AREDS 2. And we know that this, concoction here has been shown to provide a modified risk, a moderate risk reduction in our patients with intermediate AMD. So really all we can do is, recommend these to our patients when appropriate, tell them not to smoke, take care of themselves, be healthy, etc. As in terms of wet AMD, as everyone knows, anti-VEGF is the gold standard. Before anti-VEGF came along, well, there was nothing, or there was laser ablation and then photodynamic therapy. I think some people might still use PDT in sort of the refractory cases. I don't tend to. Anti-VEGF, we know that we've had 3 that we've been using for quite some time. And then in 2019, a 4th came on. And the big question is always which is used first. I just finished my fellowship a few years ago. I came to medicine late in life, and it was very easy for me during my training because we used bevacizumab. It was just a no-brainer, or it wasn't a choice really. And then I came to Wichita and I had these choices, but insurance is actually dictating it quite a bit for us. Many insurances have dictated step therapy. So you have to start off with bevacizumab first, and then, which is the non-FDA approved one, and then you can move on after that. So the 3 ones that have been around the longest, we know 2005 bevacizumab, this is the non-FDA approved one. And this was being used while everybody was waiting for ranibizumab to be approved by the FDA. And then we have aflibercept in 2011. And then in 2019 is when the 4th one came along, brolucizumab. As you can see, the molecular weight on that one is 26 kilodaltons, so it's much smaller than the other ones. And the thought is that you're going to get a higher dosage per volume, and so then this will last longer. And in the Hawk and Harrier trial, which is what brolucizumab was compared to aflibercept, it was able to go Q12-week dosing versus the Q8 of aflibercept. One of the issues, though, that after it was being used, ASRS reported 14 adverse events, pretty serious of severe retinal vasculitis and occlusion. And so Novartis went back and formed a safety committee to look at their data. And in their trials, there was about 4% of patients who had this intraocular inflammation. And so they looked at this event in those patients, and they do consider it to be a rare event, but there is some caution in dealing with patients who either have active inflammation going on or maybe have a history of it. What about treatment options for patients who present like this with a large submacular hemorrhage? So this was actually my first week out of fellowship, and I injected somebody with anti-VEGF. He was 20/60, active CNV, came back 3 days later with this, went down to count fingers. So treatment options, I list 2 here. There's actually 3. Some people will just continue to treat with anti-VEGF regularly, very frequently. I mean, 28 days right on. I know some people who do that and they feel that they can still have some good results. However, more aggressive approaches, you have your in-office approach where you can inject your intraocular gas and have face-down positioning, or surgical, PPV with subretinal injection of TPA, and then you inject gas, and then you have them do a little bit of a head tilt. I've had good results with the surgical. I like it. You always have a long discussion with the patient about all their options, and then, of course, help them make the decision. So this was the OCT of my patient, and after a talk with him, he decided to do the surgical approach. I don't have my own surgical video, but this is sort of what it looks like. You do a pars plana vitrectomy. You want to make sure you've lifted up your posterior hyaloid and done a good core vitrectomy. And then basically the goal is you want to create this retinal bleb because you want to dislocate the blood and you want it to basically go inferior. So you use a 38 gauge cannula and you create a little concoction of TPA. I like to use an anti-VEGF in there if I can, depending on where I'm operating. And then you also have to have plenty of saline solution because you need volume. And you just go to the edge of the bleb where the hemorrhage is and stick it through the retina and then inject, and you create this nice localized retinal detachment. Put gas in, short-acting SF6, it doesn't need to be in there long, and have him have a head tilt down. And so this was my patient several months later, about 3 months later, and he was down to 20/80. So he was happy and recovered most of his vision back. They don't tend to, in my limited experience, they don't tend to get their vision back very quickly. It does take months and it does take repeat anti-VEGF injections, but it can be a nice procedure to deal with these submacular hemorrhages. So what about the future? So dry AMD, all our patients with dry AMD, they sit there and they say, what is there for me? What do you have? And so we're looking at drugs that target the complement cascade because we think that is what plays a big part in the advancement of geographic atrophy. So there are 2 studies, inhibiting C3 and C5, part of the complement cascade. And I'm purposely refraining from saying the name because I won't be able to pronounce it correctly. But for the one that inhibits C3, it just completed a phase 2 trial and compared to sham, it did show a significant reduction in the advancement of geographic atrophy. It's now in a phase 3 trial. The Zimura, I think, is still in a phase 2. What about stem cell therapy? I get asked that question all the time by my patients. When are you going to be able to inject stem cells in my eyes and fix me? These trials that are out there are all very early. Your phase 1, your phase 2A, and they're looking at injecting these RPE stem cells in subretinally. The ones that I've looked at, they're dealing with patients with very advanced dry AMD to begin with 2400 vision. And so far it's very limited, but the results look promising. But I think this is something that's still a ways away. Wet AMD, what's our goals of future treatment? So number 1, targeting new pathways. We know VEGF isn't the be all and all with AMD, but also prolonging the treatment effect. So for anybody who does injections, you know that our offices are just, our clinics are just overwhelmed with people needing their injections. There's transportation issues. And it's fairly well recognized that most patients are undertreated compared to what they were treated in the studies. So one promising thing out there is this indwelling depot. So it's the port delivery system being used with ranibizumab. And the phase 3 Archway trial compared it with monthly ranibizumab dosing Q24 weeks. So basically the way it works is the first visit has to be surgical. So you've got to place this indwelling port, and you're going to do a full thickness scleral cut down about 4 millimeters from the limbus and make about a 3.2 millimeter incision. And then you're going to insert that, and it will sit there. And then they say all the sutures that you need is you just, will cover the conj over it. And then this hopefully will just need to be refilled in the office every 6 months. I think it's 100 milligrams per milliliter is the dosage. And so I think this is something promising. Obviously, there's going to be a little bit of a surgical learning curve, and some of the events that can happen, vitreous hemorrhage, endophthalmitis might be at a little bit higher rate. But I think in this trial, they had, 4 cases of endophthalmitis in the patients who had the catheter put in and treated well. 1 did not. I think 13 cases of vitreous hemorrhage, and this is out of 200 and some patients, and they all cleared spontaneously. So I think this is something that also is coming down the future and will be used for, diabetic macular edema and everything in the future. So what about some other targets? What about some other pathways? So here we have faricimab. It's an antibody that's going to be specific for both VEGF-A and angiopoietin-2. And so that is a cytokine that helps sort of destabilize the vasculature and causes inflammation. So it's thought by inhibiting both of these, you're going to have a more synergistic effect. And this also is being looking at being dosed at a longer time period. So in their phase 3 study, they're looking at it compared to aflibercept 16 weeks versus 8 weeks, which is a huge difference in modern day practice and in the clinic. Conversect is another thing that's being had. I think there was a couple phase 3 trials going on here in the United States. It's actually already been approved for treatment in China in 2013. And this is a recombinant fusion protein that's actually very similar to aflibercept, but just has an extra domain for VEGFR2. There's also KS1301. It's an antibody biopolymer conjugate, and it's going to inhibit all VEGF isomers. It's a very high molecular weight, so 950 kilodaltons, and all the others are 100 and less. So the thought is this is also going to give increased treatment durability, and it's phase 2 trial. It's currently looking at being dosed every 6 months also, which would be wonderful. What I find really interesting and exciting are the ones that involve gene therapy. This one is just still in a phase 1 study, but it encodes the gene for aflibercept, and it's basically going to be an in-office intravitreal injection. So in this phase 1 study, they've taken these patients and they're just giving them a single injection, and they're just keeping track of how long this is present in the vitreous. The other gene therapy out there that I want to mention is the RGX-314. So this is a novel adeno-associated virus 8 vector. This is going to give the cells the ability to make their own anti-VEGF protein. Now, the administration won't be able to be in office. It will have to be via parsimane of vitrectomy and create a subretinal bleb. So I'm sure there's going to be a lot of surgical curve there anytime we're going into retinal, obviously. But this is an ongoing phase 1/2 study, and the purpose of this is, to decrease that in-office intravitreal injection and burden. And it's already just the early data from it is showing some meaningful reductions. Thank you. Any questions?
Yeah. I don't practice retina, so I'm sure. You review like the submacular hemorrhage. You must review that as a risk before you inject. Like, how do people handle that?
I don't. It's really not something that I even really discuss with my patients. And they actually just came out with a study, and maybe some of the very smart residents who are supposed to be better up on this than I am. that I think they looked at the association between a submacular hemorrhage and the giving of the injection, and also, you know, the extending to see if there's a correlation, like if you instead of injecting somebody every 5 weeks, you miss 2 weeks, does that increase the risk of happening it? And I think they couldn't really pick an association. I mean, my take of it was just, if it's going to happen, it's going to happen. So I don't really discuss that risk with them. Do you, Dr. Fox?
I think the patients we see at highest risk for having that sort of problem are patients on systemic anticoagulation.
Yes.
Oh, sure.
So there are folks who see with AMD that are at the highest risk to have a poor outcome. So I don't think patients at the primary diagnosis of wet macular degeneration have to be told every glorious detail bad things, but they all are aware of the possibility of decline in their vision despite treatment with anti-VEGF. This is one of the manners in which patients can lose vision. And those patients with anticoagulation, I think all of us are much more energetic in trying to maintain those patients on very high, regular therapy, and a little less likely to extend or let them be wet at all, because they're more likely to bleed. So those patients, the anticoagulations will be on.
You conversely treat them more, actually.
Right, we treat,
exactly.
I think most of us feel it's a lack of control of the choroidal neovascularization
Right.
rather than the side effect.
So it was a coincidental, it wasn't related, basically.
I mean, they don't.
No, I don't think it really is.
Same.
That same patient could have bled 3 weeks later. and
Exactly.
not treated them.
Yeah.
It's inadequate control of the neovascular process.
Right.
Rather than, it's a different story than creating an RPE rip or
Right.
something like
Yeah,
that.
sure.
Right.
Cause neovascular to contract, which can
Sure.
cause some bleeding.
Right.
Some problem, but this is different.
Well, thank you so much. That was a great update. Next, we have Dr. Nasrazadani talking about space occupying lesions of the orbit and 10-year retrospective review.
All right, well, my name is David Nasrazadani. I'm a PGY3 resident here at KU. Supervisor for this project was Dr. Sokol. And the title of this is Space Occupying Lesions of the Orbit. It's a retrospective review. So kind of the basics of this and what we're looking at was a wide variety of processes that can produce space occupying lesions in and around the orbit. There's a lot of different things that can cause this. Neoplasms, vascular lesions are very common. Inflammatory diseases, congenital lesions, and infections. And a lot of these things can arise from different structures within the orbit. So the globe and nexa, the lacrimal gland, orbital fat, muscle, and vascular structures. And so what we did was a retrospective chart review that we performed on any patient with orbital space occupying lesions that required biopsy and histopathology from 2010 to 2020. All of the lesions that were biopsied or surgically removed were treated in our department between 2010 and 2020, and they were identified by surgical CPT codes. In each case, we recorded the gender and the age of the patients, the pathological diagnosis, number of re-interventions, laterality, histopath findings, and associated morbidities and mortalities, including the morbidities include a lot of the re-interventions that were done. So among our results for a 10-year period, there were 338 procedures performed on 291 different patients by a single surgeon. There was a slight predominance of male patients, and the average age at the time of the procedures was around 61, the youngest being 6 months and the oldest being 98 years old. So out of the 338 procedures, I kind of broke down the numbers here. You'll see the most common procedure was orbitotomy with the removal of lesion, which was that certain CPT code. That was about 32% of the procedures. I also see orbitotomy with bone flap, orbital exenerations, orbitotomy with drainage, and then with and without bone flaps, and exploratory orbitotomy. And so there are a lot of results here. We'll go over some of the more common ones. So over this 10-year period, the most common were actually benign lesions, including lipomas, papillomas, and granulomas. That was around 15 to 16% of patients. The next after that were infectious orbital cellulitis. And out of the 39 patients that we diagnosed with that, 9, which was about 23%, had mucormycosis, and 3 of them, which was about 7%, had aspergillosis. The next few common ones were invasive carcinomas, including squamous cell, basal cell, metastatic adenocarcinoma, and lacrimal gland carcinoma, and then also those with inflammatory disease, including sarcoid, IgG4-related disease, or just inflammatory diseases that we couldn't really diagnose. There are other benign lesions, including dermoids. There were some vascular malformations. Importantly, also lymphomas were also around 8% of these results. And then other things like meningiomas were also quite common. And then toward the bottom there, you can also see that around 8% had no abnormal findings on pathology. So they just had these masses that we just didn't know what they were. Or they just could have just been like fibrous tissue or fat. Additionally, we also did look at the re-interventions. So among this 10-year period, there were 62 re-interventions on 39 patients, which represented about 18 to 19% of the procedures and 13% of the patients that we looked at. And then nearly an equal number of procedures involved the right versus the left orbit. And so this was our data over a 10-year period. So I looked at some other institutions' data. This is a study that looked at nearly 2,500 space-occupying lesions over a much longer course of time. And this went from 1976 to 2011. So similarly to us, I mean, the majority of their lesions were also benign, around 68%. Most of those being dermoid cysts or cavernous meningiomas. So they put together a lot of different benign lesions where we separated ours out a little bit more. But they also had quite a few, 32% that were malignant, including lymphoma, basal cell carcinoma, and orbital mets. And then and this particular study, which we didn't do, did look at kind of the distribution within the orbit of the masses that they found. Most commonly, masses would be found supratemporal, and those were dermoid cysts. You can also see basal cell epitheliomas were usually intranasal, and meningiomas were typically in the central space. And then I also looked at a study that looked a little bit about what we looked about, where we were looking at re-interventions, usually because of recurrence. So this study looked at recurrent oral space occupying lesions. And so they looked at about 250 cases of all different ages. And then the last recurrence interval after the operation. So typically that ranged from 1 month to even as much as 40 years. So a lot of different numbers here, but most commonly, the one reoccurrence was the most common thing that you would see naturally. And then the more reoccurrences were more rare. And then around 230 of the cases underwent surgical removal of recurrent orbital lesions, and another 22 cases had to receive an exoneration. So they were looking also at the most common recurrent orbital lesions. Usually lacrimal gland tumors were the most common. Vasogenic were also very common, and neurogenic tumors were also very common. And so again, kind of reiterating, lacrimal gland pleomorphic adenomas were the most common diagnosis, and also lymph and vascular formations were also very common to reoccur. So among some of our conclusions, obviously space occupying lesions, they represent an important part of our practice. They can carry significant morbidity and mortality. As we saw, we had quite a few malignant lesions that do go to the orbit, either originate in the orbit or metastasize to the orbit. And a lot of these lesions do require re-intervention. And we also looked at different imaging studies. I didn't really report a lot of these too, but just from reviewing the data, a lot of these MRIs and CTs, while they're useful for looking at where the lesions are, they're not great at actually diagnosing. Interestingly, a lot of them commented on all these, calling them meningiomas. That seemed to be like the most common thing that they like to report, which did happen quite a few times, but also a histological examination was very, very important, and diagnosed a lot of other lesions that MRI by itself couldn't diagnose. And the future things that we can look at, again, we can look some more at re-interventions, or we can look specifically at certain things like lymphomas or other malignant lesions and see how common these are and how many re-interventions these cause and how many actually led to exoneration. Further data that we can collect. Special thanks to Dr. Sokol, and that's all I have.
Are you going up over the 10 years or stable for 10 years?
There was an original study that was going from 2010 to 2014, which I continued, and the numbers actually stayed about the same, like the actual breakdown of the numbers were fairly similar. And so mine was about 6 years worth, whereas theirs was 4. So I had higher numbers of each, but the actual split was about the same.
Is it, with people knowing that Dr. Sokol would do this sort of thing, if Brian's going up?
You know, it's an yeah, just leave it. We do have more plastic surgeons now in town. But most people, they avoid it, or at least they don't.
Yeah.
They hate it.
Next up, we have Dr. Stefonowicz talking
Yeah, we just
about
want to look at that.
The impact of COVID on resident training opportunities.
Well, like Dr. Alapati said, I'm Dr. Stefonowicz, Chris, and board of residents, and a graduating student. Quick for help with this project. So I'll talk to you as if you guys don't know what COVID is. SARS-CoV-2 was a virus that pandemic. So on March 11th, it was actually declared a global pandemic by WHO. Completely uprooted another community, profoundly affected medical education across the world. Many of the resident training programs were forced to suspend all clinical and surgical activities. For residents to areas outside of their specialty, which disrupted their training greatly in many parts of the country, around the world. So with the lasting consequences of the pandemic still pervasive within our practices today, I wanted to ask the question, how large of an impact did the pandemic have here in Kansas City within ophthalmology? So looking at a study that was conducted by the Royal College of Ophthalmologists back in July of 2020, kind of at the peak of the pandemic, they got 504 different responses from residents across 32 different countries. And it reported that about half of the trainees said that the impact of COVID had severe effects on their training, with about 3/4 of them saying that they had a greater than 50% increase in clinical activity, and about 3/4 of them saying that they had a 75% increase in surgical activity. Of the 504 responses, about 2/3 of them shifted to some form of web-based teaching of the pandemic, and a lot of them found this to be really helpful. Greater than 85% that shifting to web-based learning was beneficial to them. So how did we handle it at KU? From March 11th to March 24th, once the pandemic was kind of called that a pandemic and implemented, then we suspended all of our clinical and surgical and didactic activity for about 2 weeks. And then starting on March 24th to May 15th, we were placed on a kind of a 3-week rotation where 3 residents would be on for the week, and then we get 2 weeks off. There'd be 1 resident from each class. The PGY4 would cover the VA and all surgical cases that happened at the VA, Children's, or KU. PGY3 would cover the clinics, and so we'd be here for any clinic visits that need to be seen urgently, CMH clinics or consults from an inpatient side, and then any remaining surgical cases that weren't able to be covered by the PGY4. And then the PGY2 would cover consults received from the KU inpatient service and the emergency department. Continuing until kind of middle of May, and then by May 18th, we actually were able to resume our clinical rotations as scheduled at a reduced rate. And we're kind of continually been ramping up since then. We're pretty close to back to full volume at this point. So this is a survey I sent out to our residents. Our residents struggled with this question apparently because there's actually, I sent the last year's residents as well, and so this should be 3, this should be 3, this should be 3, and the PGY1 and 2s only have 2. So we actually have more data from older residents, which I think is more beneficial because the PGY1s and 2s weren't actually ophthalmology residents at this point. So I asked how much did the COVID pandemic affect the surgical volume and experience? Overwhelmingly, people thought it was negative. So it didn't severely affect their surgical training, but they felt they had some negative impact. With 1 resident saying that it had no effect on their surgical training, like the PGY1. How much did the COVID pandemic affect your clinical volume? Again, about 75% of the residents felt like it had somewhat negative effect. Again, didn't severely impact the clinical training. This was interesting in that we got kind of a mixed bag of how residents felt it affected their didactic training. Some actually felt like it was a positive move or had no effect on their training. About half, it was about a 50-50 split. So some felt it was negative and others felt positive, no effect. And when we transitioned to Zoom lectures, which we're still kind of doing a hybrid Zoom lecture model, we have some in person, some on Zoom. Again, kind of a 50-50 split here. About half felt that it was positive using Zoom, and others felt that it was negative. I think the largest thing, the negativity, is that I feel like you probably don't have. I know personally, when I am on Zoom, I have kids at home and a wife, and so I feel like I'm constantly being pulled in other directions. So sometimes your attendance maybe isn't as good if you're sitting in a lecture hall. Gives your full attention on the presenter. And then what overall effect did the pandemic have on your training? Largely, people thought that it had a negative effect. There was actually one resident that felt that it had a positive effect. And then I just was curious to know if it had any role to pursue fellowship at all. I think by and large, it didn't really have much effect on the decision to pursue a fellowship. So a quick summary of results from March 2020 to May 2021. 91% reported a somewhat negative effect on surgical volume, 73% on clinical volume. Half their residents reported no effect or a positive effect on didactic training, and 45% that Zoom didactics have been beneficial. Overall, 64% of residents felt the pandemic had a negative effect on their training. Actually, that improved the training. Didn't affect fellowship decision at all. Some of the limitations of the study is that it's a small sample size. It's just our residency program, and it's a small geographic area. I think that if you surveyed people out in New York or around the East Coast, and this took place on the West Coast, I think their experience may be a little bit different on the impact it had on their training because they were hit harder. Some takeaways or future directions. I think we've learned that we can transition quickly to web-based didactic training, and actually a lot of people find this to be beneficial, and it's something that we may adopt going forward, especially for residents that are off-site, either at the VA or at Children's. It's a good way to continue education. I think we learned that it's important to have a good wet lab or surgical model training models, because when all surgical training was suspended for a period of time, if you didn't have a wet lab or some area that you could practice, you basically were left without any resources to train for surgeries in a surgical residency program. And so I think incorporating those into residency programs across the nation is, I think, highlighted, the importance that is highlighted with the pandemic. And then kind of with the advent of virtual reality and virtual curricula, I think that we can start to explore virtual patient encounters and virtual physical exams that when you can't see patients, we can at least keep up to date on these skills. Any questions? Yes.
You just look at your surgical numbers of the graduating third year class compared to pre-pandemic and see how significant that impact was on your numbers of cataract numbers or retina numbers.
Yeah, I didn't directly compare that, but we actually just a couple of weeks ago presented our numbers as seniors, and our numbers actually were fairly good. We were lucky in that our VA system kept it running pretty well. And so I think most of the graduating seniors last year ended with around 300 cataracts or so. And this year, I think the lowest we had was you're still at the VA right now, and you were at 200. And,
yeah, I think all of us went at 300 this
so
year.
we'll go over 300. So actually, we got pretty lucky.
Yeah.
Despite losing 6 weeks of surgery, they speeded up afterwards. Caught up.
I think it's interesting you focused on like volume, but I'm sure there were other consequences as well, right? Like, collegiality and having support because you can't be together. I think there were probably other variables too.
Yes, this is a little off topic, but how are you anticipating adding a fourth resident perspective? Because those are great numbers, cataract numbers. You think you guys will be able to maintain that rate?
Well, we're at the 95th percentile.
Yeah.
The rest really almost imperceptible effect.
Yeah, that's a wonderful number.
There will be a small number decrease, but
but the volume is there.
Theoretically, when you get past 100, you're already operating 3 times as fast as you will. And what you get out of the next 150 is a few chances to
Right, right.
So if you do fewer, you maybe get your applications early.
Yeah, those are just wonderful
Yeah,
numbers.
So the numbers are
Program.
good. The numbers will be solid. That's why we were already approved for. So it was easy for us to fix.
Wonderful. That's
We've had
great.
like 300 to 400 plus. I think there's quite a go around that they can distribute.
That's great, yeah.
We're gonna actually skip ahead a bit to kind of catch up on time. So we're gonna have Dr. Kimple talk next about musculoskeletal injury incidence categorization and potential prevention among ophthalmic surgeons.
All right, well, good afternoon, everyone. I'm Travis Kimple, PGY4. I'll be talking about musculoskeletal injury, the epidemiology, categorization, and potential prevention of this among ophthalmologists. It's a literature review. No conflicts of interest here. Kind of objectives. So there are about 25 studies included in this analysis over the past 20 years. It's basically everything that's out there on this topic. We'll kind of go through the prevalence first. So all literature on this topic shows that musculoskeletal disorders are very common among ophthalmologists. I'm sure that's no surprise to anyone. First study we'll look at here is a 2005 survey. Most of these are survey-based studies, so they're a bit limited in that regard. But the 2005 survey showed that 52% of ophthalmologists reported neck, upper body, or lower back symptoms, and 15% of the participants said that it actually limited their work, so that's a pretty substantial impact. A 2012 case control American survey study showed that there are actually higher rates of musculoskeletal complaints among eye care providers compared to family physicians. So for example, like 46% versus 21% for neck pain, 26% versus 9% for lower back pain. More recent studies, a 2019 survey-based Canadian study showed that 50% of ophthalmologists reported musculoskeletal pain in the past 12 months, and neck pain was the most common at 46%. A 2020 American survey study showed that 66% reported musculoskeletal pain, 70% complained of pain in their neck, 48% in the upper back, 44% in the lower back, and 16% in the upper extremity, including the wrist. There were higher rates in those that operate frequently. We'll skip this slide here. The studies did identify that there were kind of two postures that were most implicated in musculoskeletal issues for ophthalmologists. The first one being forward head posture, which is classically kind of defined as your head being more than 20 degrees in front of your kind of aligned spine, shoulders. So this can result in numerous injuries, including muscle strain, disc compression, spondylosis, and spinal cord compression. Sitting can also be an issue with 40% of your 40% higher rates of disc pressure when you're sitting, 200% higher disc pressure when you're leaning forward. And as we all know, our clinical environment does not encourage good ergonomics or good posture. So our indirect ophthalmoscopes, our slit lamps, our surgical microscopes all will induce awkward postures if you're not very careful about it. Our exam chairs oftentimes will not be elevated sufficiently, and it's hard to get the patient in a position where you can really maintain good ergonomics. Our surgeries often involve prolonged repetitive motions and static postures for a long period of time, so that doesn't help either. There are also high patient volumes, and there's limited time, at least we perceive there to be limited time to have good ergonomics, but we'll talk a little bit about the positive side of things now, stop being so negative. So there's a task force from the AAO that will help us, I think, figure out what to do here in terms of evidence-based interventions. But first, I just want to highlight that there's a 2020 Indian study that showed that only 27% of ophthalmologists there felt that they had received adequate training, literature, or other educational material about musculoskeletal injury. And that would certainly suggest this is a worldwide problem, and it's probably still an issue here as well, that a lot of us could use more education about ergonomics. And so the AAO task force on this is very helpful. You just go to the AAO website and type in task force on ergonomics, and this will come up. It gives you access to numerous peer-reviewed publications, presentations that can be helpful. So let's go through some of these solutions. The first thing that's suggested for the clinic or the office is to elevate your chair and adjust your slit lamp so that you're in the most upright position and as close to the patient as possible. So in this scenario, you can see that this gentleman is getting close enough that like his knees are like at the level of the patient's feet. So he's very close to the patient. That kind of helps maintain more of an erect spine, avoiding like a forward head posture. Varying the instruments and switching your hands as much as possible is a good idea just to prevent repetition and static movements. And that applies to the OR or the clinic. Standing desk can also be helpful to prevent like prolonged sitting. That can also be applicable both like in the clinic or the office. So like at KU, we have adjustable height computers in the exam lanes. That can be pretty helpful for allowing you to stand like when you're seeing patients. It doesn't work if you're over like 6'2", but it's good for a lot of us. Solutions outside the office and the OR, you want to probably invest in a pillow that allows your spine to be in alignment, not torque your neck down or up. All of us use our phone a lot, and it's hard to avoid that because frankly, we do a lot of work on our phones, but avoiding constantly flexing your neck when you're looking at your phone is a good idea. I don't think you have to go as far as getting a supporter here, but you can consider it. There are also several exercises that you can find on the AAO task force that can give you strengthening of your supporting muscles of the neck and spine. We don't have time to go into that. Finally, though, utilizing your vacation time is kind of obvious, but rather than maybe going to something where you're going to be sitting at the computer all day, like actually using your vacation time, doing something different, getting out there, maybe in the outdoors and changing things up a little bit could be helpful to reduce the prolonged strain. Finally, some solutions in the OR. So taking the time to adjust the table height, the stool, and the eyepiece position so that you're maintaining an erect posture and minimizing neck flexion. Using lightweight loops if you do use loops with a generous working distance. And a large angle of declination. So this is showing that here. The surgeon is not flexing his neck very much thanks to a good set of loops. And then finally, finding ways to maybe break up your OR days by integrating some form of case variety or maybe breaking up the blocks into 2 separate blocks in a week. Finally, this is something I'm particularly interested in is whether or not heads-up displays can potentially prolong careers and help. So there are a couple of studies that I'll highlight here. Both are unfortunately survey-based, so they're not reliability and what you can interpret is limited there. But one is a Saudi Arabian study, the other is an American study. They basically looked at rates of MSK pain intensity and those who use them versus those who don't. The most common one that I see in the United States is True Vision. There's some others that are out there, but the Saudi Arabian study did not show a statistical significant difference, but the American study was more supportive of rates of musculoskeletal pain being reduced when using heads-up displays. So there are a lot of other studies, though, that are more anecdotal, just talking about the positive perception of these heads-up displays and reducing, especially neck pain and potentially lengthening the careers of ophthalmologists. So I think that's pretty interesting. Time will probably tell whether or not these will be seen more commonly in our practices. So in conclusion, these complaints are very common among ophthalmologists. For most of us, neck pain is going to be the primary issue. And the available literature supports that there are several preventative measures to use in practice to reduce MSK injury. Most of these actually primarily sacrifice time rather than money, but I would argue that a long career is worth a lot. So just something to consider.
All right, thank you, Dr. Sokol, for being my mentor. I'll take any questions.
Travis, did you look at if there was like any new stuff coming out to help with some of this like more ergonomic chairs, like for the OR, like the chairs that we use versus anything else that's available that supports more ergonomics, like slip lamps that are more mobile, that can like come up to you more rather than being very stationary?
I didn't see anything on new devices so much, but there was a study that talked about the use of a wrist rest, which is an old device. I mean, that's been around for a long time. And, this study supported the use of a wrist rest, but many of us just don't like to use them. So I think it's kind of, if you can tolerate a wrist rest, it might be helpful. But
Your core strengthening probably is really important too, right?
When you guys can get out and afford it, the best money you'll spend is a physical trainer. And they'll teach you how to strengthen your posterior chain, which we're hunched over the entire time. And physical therapy is probably the most important thing because you will blow your neck after 25 years of this. You'll blow your neck. It happens.
Not everyone's good at straighter.
It's very timely. My co-host, Dr. Champion, is currently debilitated by like a neck muscle, so it affects us all. Next up, we have Dr. Jennifer Burgoyne coming to us also from Wichita. There's a little setup, Wichita representation in the house today. She's going to review cataract surgery waste intervention project, the surgeon's one-year effort to reduce, recycle, and reuse.
So while I blew my neck last year and had an emergency fusion, I really got interested in writing this up. So this all started a couple of years ago when I saw an article in one of the throwaway journals about the wastefulness of cataract surgery. And so I decided to see if I could do something about it personally myself. So this is now, we're on year 2 of this, and this is an ongoing project. So this is my efforts to reduce, recycle, and repurpose medical waste from just one surgeon. And I'm from Wichita. I run my own practice. You can still have a solo practice. I'm a comprehensive ophthalmologist, and I do a lot of everything except for retina. Dr. Nesmith. Here we go. Here's my project description. Cataract surgery is probably one of the most frequent procedures done in the United States. Somewhere between 3 to 4 million are performed each year, depending on which article you look at. Most are performed in an ASC. In general, cataract surgery is a very clean surgery. There's very little respiratory aerosolation, any fecal material, little blood, unlike the colonoscopy people down the hall. But we generate a lot of waste from just one small case. And so I wanted to see if I could do, this is gonna be a little out there, so that's why this included me. Cataract surgery has a really high carbon footprint. Some studies from the UK looking at all sources that contribute to carbon dioxide equivalent estimated that, at least in that study, 181.1 kilogram carbon dioxide equivalent per cataract surgery. Most of the carbon dioxide footprint came from packaging and procurement supplies, not necessarily travel or building energy consumption. I don't know whether you guys are all familiar with the Aravind Eye Hospital system in India. They are the model for efficiency. High volume, incredibly small carbon footprint. So when I read their study, reported on by Dr. Cassandra Thiel, their approach to cataract surgery and recycling and repurposing is probably something we're not going to be able to achieve here in the United States at this point, but it's something to emulate. Here in the United States, everything is single use. lots and lots of packaging. Just for example, your little cataract boxes, they've got like that thick booklet of paper in it. That's all waste. And very few surgical facilities actually have a dedicated recycling program or even want to look at it because it's very expensive and time consuming. So this was my experience. We're at a multi-specialty ASC where we do a lot of cataract surgery and colonoscopies in 2 different parts of the building in different rooms, and some plastic surgery and general surgery. And I looked at this from March 2019 until we ran into COVID mainly. This was a process. I decided the easiest metric to do it was just measure the amount of waste. I just looked at every single case I did, cataract surgery. So year 1, I tried first to, let me go over the project team. I had to get permission from my administrator. I had to get buy-in from the circulators and everyone else there because this was a little bit of a setup to start with. And I also had cooperation from the EyeCon surgical rep because they had lots of questions about all of these plastics. Let me play this real. Bear with me, this is very early.
This is Dr. Jennifer Burgoyne, and this is my recycling or repurposing project that I'm doing, looking to reduce the biological footprint of routine cataract surgery. Most of these drapes you see in front of you have never been anywhere near a patient. They're just sterile wrappings. These are the mountain of gowns that we use for routine cataract surgery that don't be contaminated with anything. Most of these are just sterile, clean wrappings or cover a table, and they're all put in the trash. These are the Mayo covers that are turned inside out and are now essentially heavy duty trash bags. I am actively looking to repurpose these materials in an effort to reduce the footprint of cataract surgery. Here is other potentially recyclable or materials that could be repurposed that were not used or contaminated in any way during routine cataract surgery.
Okay, so I took like these worth of stuff to my house. It was clean. So I had a pre-phase. First of all, I had to just, I wanted to know, was there any type of medical recycling available in Wichita, Kansas, or the local community? The answer is hell no. There is no commercial waste vendor that accepts any type of blue wrapping recycling anywhere, not in Wichita, Kansas. Now, in large metropolitan cities with big hospitals, they have some programs there where all of the blue wrappings, all of that stuff can be recycled. Nothing, at least in Wichita. There was no on-site recycling for any materials other than the big cardboard boxes at my ASC. There was some isolated efforts by nursing staff to repurpose clean materials like the little blue towels. The nurses would scoop those up, or someone would be doing a aluminum can drive or just sporadic things. So my first phase was, what can I do about my pack? Everybody has a surgical pack for cataract surgery. So was there anything in my pack that I wasn't using routinely or we didn't need? So we eliminated everything that was in my pack that I wasn't using on a routine basis. I also looked at the body drape, and here's a picture of this massive body drape, and I abandoned that and used this 1/4 nice little transparent body drape that only covers like right down to the midsection. The anesthesiologists actually love this because they saw the patient a little bit better. I was able to see the patient better. Patient was a lot less claustrophobic, and it actually saved us a little bit of money. So that was the pre-phase. Phase 1 was reduce the cataract pack materials. We eliminated the body drape. We removed unusable stickers, excess medicine cups, marking pens, paper rulers, unneeded syringes, and towels from the pack. Phase 2 was, of the things that were left for the case, was there anything we could do with it? So I balled it all up on the floor and measured it, and it was about 6.5 pounds per case. And then I created a sorting system. Contaminated trash, things that could be recycled, and things that I would try to upcycle. So in the trash were the things that actually touched the patient or were actually contaminated. Those either went in the sharps container or they went in the trash. So like the drape that touched the patient, any type of instruments. So all of anything like that that couldn't be recycled or upcycled or was contaminated went to the trash. And then we prep our table in another room and bring it in. So all of these little plastic jobs over there, I saved in a bag, and we sorted them. And multiple of these materials can be recycled. Probably the thing that was maybe a little unorthodox is I put all the surgical gowns, the gown that covered my chair, the gown that I wore, and the gown that my scrub wore in a bag. And then we put drapes and wraps and coverings that were not contaminated in another bag. And here's just a picture of, here's one case, and then how we sorted it. This is the only thing that goes to the landfill. Everything else I'm repurposing or recycling. And where does it go? Well, it goes in the back of my car first. Lots of the blue trays are happily received by art classes and science classes. And I actually have been doing blue tray recycling for 20 years in Wichita. And many elementary and science classrooms and art classrooms are the benefactor of my little blue trays. These are number 5 polypropylene. And if they're not dirty, they can be, don't throw them away, they can be recycled or upcycled. The biggest use of all the blue stuff is I give it to the vets and the Humane Society and Animal Rescue. They love it, they use it, they don't have problems with re-sterilizing things or reusing things in the veterinary world. So the Humane Society is on my way back to the office from the surgery center. So every Monday I make a massive drop off of drapes, towels, coverings, and the gowns. They have to use the gowns for dogs in isolation when they receive the dogs. So they use these gowns every single day. And the Humane Society processes like 9,000 animals a year in Wichita. So they are constantly using that. The other thing that I really stuck in my craw was how much plastics we throw away that are actually clean. And so I've laid them all out here. And I actually called EyeCon, nagged them repeatedly to give me the information on what some of these plastics are that aren't stamped with a number. And at least half of them are still PETE. And I don't know why they're not stamped. I'm still digging at them to kind of get information. But all of this stuff here is stamped with a recyclable number and is clean and can be recycled. I upcycle these two things. These two things go to the schools. So I take them to various art classes, science classes, and they use them for whatever science art projects they do. So what was the outcome? The outcome for phase 1 for me was we actually reduced the body drape, which had something that was actually turned out better for the patient clinically. patient was like a little less claustrophobic. They could see the anesthesia, could see the patient better. So that was actually a clinical benefit for the patient. There was some cost benefit in reducing the pack materials. It did take some time to get this done, but we have a little bit less expensive pack. And in phase 2, depending on individual cases, we reduced what was sent directly to the landfill by 50%. We saved 3 pounds per case. So we reduced the pound per case to 3.5. The greatest contributor to waste right now is the unused irrigation fluid. And then I estimated I do about 500 cataracts a year. I'm saving at least initially 1,500 pounds of waste going to one of our local landfills. So this is my little Mayo stand, and here's the table. I have a lot of thoughts about how I wish we could do this in the United States, but I don't know whether we can yet. Project impact is you actually can reduce your waste. Most of the stuff that we do is extremely clean, not contaminated, and really doesn't belong in a landfill. One of the unexpected community benefits of this effort is the Humane Society is saving about $10,000 a year in supply costs, just by me chucking my stuff over there. During COVID, we were able to donate some gowns, and they re-sterilized them and used them. But one of the things that has been really beneficial is this has really raised awareness among the ASC staff, and everybody's now looking to take things that can be upcycled instead of just chucking them in the trash. And I have secondary and third measures that we're going to start working on. I think as cataract surgeons, and this is such a high volume procedure, we really need to look at sustainability and whether or not, I mean, maybe we can wear the same gown for more than one case and just change the gloves. You know, maybe the back table cover doesn't need to be changed every single time. You know, it would be nice to have a prospective study that looks at that and what's the final outcome. You know, is it endophthalmitis? Is that what we look at? I mean, that's what we always, that's our number one feared complication as a cataract surgeon is endophthalmitis. And I would gesture to say that changing your gloves and wearing the same gown for 3 cases or 4 cases or who knows, they do that in Erevan, and they have their endophthalmitis rates are lower than ours. I inject moxifloxacin at the end of all of my cases. I haven't had endophthalmitis for years. And I don't think it's because I'm changing my gown every single time. So as you are blossoming into high volume cataract surgeons, as our nation will require of us, I challenge you to start thinking a little bit about sustainability and what we're throwing away. And also I griped out my EyeCon rep about the little booklets. And so they're going to QR codes on a card. And EyeCon is actually going to get rid of the number 6 polystyrene. And we have to open one of these every case. So this is just plastics from one little case. I mean, 3 million of this a year is a lot of plastic. So if you can recycle it, look to upcycle it, and reduce your packs. That's it.
Seems like that'd be interesting to get the American Academy of Ophthalmology involved with, because as an ASC owner, doing ASC surgery forever, you know, initially we used to be able to reuse something like a laser, or and now our biggest fear is to make sure we never get the state auditor to think we do anything wrong. And so they just seem to hype on more and more things that we have to do to make sure we look like we're more sterile, not less sterile.
Yeah.
So have the academy involved. For an individual to do it, it just seems hard to get a lot of.
So that's why I only included myself. I didn't. I'm going to actually write this up in a, I guess, more scientific way. And we're going to do some more metrics again. I mean, technically, I'm probably breaking some rules, But I wanted to do it anyhow, because I think it's actually legitimate and it just got to start somewhere. Someone's got to stick their neck out a little bit. And I mean, we took this stuff to the vet, to animal rescue. I mean, it's not like I was trying to put it on, so, and the vets are just overjoyed to have this stuff because they recycle and, I mean, they reuse and re-sterilize a lot. So I think it's a dialogue that needs to be had. And I think we have to, I mean, we are the ones that are gonna have to make the, squawk a little bit about it, so.
Are there studies out of India? Because like I've operated there, I mean, it's.
The biggest study is the one by, her name, and I've actually contacted her a couple of times, Cassandra Thiel. She went over to Airvund Eye Hospital and measured literally what is their carbon footprint compared to what the carbon footprint is here in, well, the UK. I mean, it's staggering how little waste they create, and they crack out like 300 a day.
Yeah.
So, but it's a totally different paradigm than what we do here.
Sure.
And I mean, it's gonna take a lot of regulatory revisions before someone can actually wear the same gown. Yeah. Now, if everything gets shifted into the office, if cataract surgery gets blasted into the office, then that is gonna be a different paradigm, different level of regulation. Okay, thank you.
It's really interesting. Next up, we have Dr. Fox, who's going to give us an update on diagnosis and treatment of primary vitreoretinal lymphoma.
Organizing the meeting. Thank you for I'm going to be talking today about a relatively uncommon vitreoretinal condition, but I have to assure you, coming into practice in Kansas City, when these patients came who had not been diagnosed correctly for about a year, and constantly been managing the patient for another 7 years. So personally, it's a disease that kind of close to my heart. Something that made somebody think I knew something. Straight out of fellowship, and that's kind of nice. And it's an interesting problem, and that is ocular involvement in primary CNS lymphoma. We're going to talk today about how it presents, how to establish a diagnosis, treatment options for both the eye and CNS disease, and maybe even some prognostic information for the directions. The ocular involvement in primary CNS lymphoma presents in generally older age population. The median age is at 60. There's a slight female preponderance in this disease. And in the ocular structures, primarily the retinal, vitreous, and sometimes the optic nerve or the sites of involvement. It's most commonly a large B-cell lymphoma, although occasionally it can be a T-cell lymphoma. And ocular disease is most commonly associated eventually with brain parenchymal lymphoma. But on occasion, patients will present with eye-only involvement and present that way for a number of years before their CNS disease develops. And of those patients with primary CNS lymphoma, 15 to 25% of them have ocular dissemination at the time of diagnosis. Although interestingly, I've never had the CNS lymphoma experts send me a patient for the eye disease. All the patients that I've taken care of in my practice have been patients with a presumed atypical uveitis that we made a diagnosis of lymphoma and then involved the oncologist from that direction. Primary CNS lymphoma was studied in 2008 in a large retrospective group of 221 patients, and only 3% of them presented with only eye disease, that is primary vitreoretinal lymphoma. Patients with primary CNS lymphoma will present relatively quickly with only about 3 months of symptoms before they're diagnosed. They'll, although many of them will have eye complaints, they'll present with cognitive changes, hemiparesis, sometimes inability to speak, aphasia, or seizures or headaches. But in those rare patients that have only ocular involvement, what does the disease look like? It's generally bilateral. There'll be some inflammation in 64 to 83% of the patients. And the majority of patients are adults, but it can occasionally develop in teenagers and children. So you need to think about it in all patients. The primary complaint that patients complain of is of a lot of floaters. Those floaters we'll look at in subsequent pictures. The vitreous haze can be significant, but interestingly, these are uveitic type conditions where the patient's visual acuity is a lot better than what we see clinically. So it's a person that you start seeing in uveitis patients with lots of findings and their vision is pretty good. Start thinking of this condition. We'll be looking at some of these other things in pictures. This is what the vitreous inflammation can look like. It's sort of sheets of atypical cells along the vitreous fibrils. That's a pretty nifty picture of a very severe case. Not very commonly are they that packed in, but you get these just sort of funny looking cells stringing along vitreous fibrils. And there's another picture of some of the vitreous inflammation you can see behind that lens implant, hopefully, if the lights aren't too bad. But the other comment is these patients aren't red hot. Their eyes are very uncommonly deep red. Their conjunctival and scleral inflammation tends to be relatively minimal. Although the occasional patient can present with severe anterior segment inflammation and pseudohypopia. This is the pathognomonic finding of vitreoretinal lymphoma. That is this creamy yellow subretinal deposit. And it has what we call that typical leopard spot appearance. So if you were to be taking an examination to get certified, this is an appearance you might want to be able to think about here. And that is an idea. And interestingly, sometimes patients will present with or without therapy and be followed for a while, and you look at their pictures and you'll see that some of the lesions are coming and going, that the lesion in the subretinal space will resolve and leave some atrophy or subretinal fibrosis in its area. Fluorescein angiography can be helpful in primary vitreoretinal lymphoma. If it's abnormal, you'll see sometimes some granularity on the fluorescein angiogram or blockage, late staining. But what's really particularly uncommon is cystoid macular edema. I have seen in some of my study clubs cases of primary vitreoretinal lymphoma with a lot of retinal vasculitis, but that's the atypical case. Most of these patients are uveitic patients without CME and without a lot of retinal vasculitis. And fundus autofluorescence can be very helpful in showing the effect on the retinal pigment epithelium in these patients. One caveat, use more fundus autofluorescence to really show you a lot of disease you might be missing when you're looking at an eye. And those are some pretty nifty pictures. And on our OCT, which you start getting on every patient in clinic, this is a disease that sits in the subretinal space. It's not in the choroid, and you'll see these hyperreflective infiltrations underneath the retina, and sometimes within the retina, you'll see some hyperreflective material. The RPE can undulate, like you can see in these pictures, and this can be helpful. How do we make the diagnosis? We do a vitrectomy. Sometimes if the patients come to see you and they've been put on steroids because they've been diagnosed as uveitis, you might hold those steroids for a little while to let the inflammation of the vitreous build up a little bit. The vitrectomy is not difficult, but some of the things you can think about doing is to turn air on. Even in a phakic eye, you can continue to see with biome now through the lens, and if you have air infusion going on, you can get at least about 2 cc's of vitreous to send to the laboratory for diagnosis. And if that makes you really uncomfortable, it's okay also to turn on the infusion with infusion and then take good care during the vitrectomy to keep pointing the vitreous at as cellular vitreous as you can. Then you get a more dilute specimen, but hopefully get as pure, a relatively pure specimen. If you just stick your projector in the middle of the vitreous and turn on the infusion and just suck there, you'll get a very dilute specimen that might lead to your difficulty in making the diagnosis. This is a relatively tough thing for the pathology lab to secure this diagnosis for you. It's important you call the pathologist before you do your vitrectomy and obtain your specimen so that they know it's coming. You're not going to put this in formalin. They need to have a fresh specimen. It needs to go straight to the lab. And they can do flow cytometry and immunohistochemistry of the cells, looking for those B cell markers on cells, brown positive markers, B cell lymphoma by immunohistochemistry. You'll even get the aggressive cytopathologist to be able to make that diagnosis based on the immunohistochemistry of several cells on the slide. And then flow cytometry can be done, and it can identify that these cells are malignant, that is primarily all kappa or lambda light chain dominant, and help you make the diagnosis. If the vitreous specimen is not diagnostic, a subretinal biopsy can be done, particularly if you have a patient that has those yellow kind of infiltrates, say, and we try to pick a biopsy site right adjacent to abnormal and normal material, and you make a little retinal break and can suck some of that material out, and that would be a relatively highly diagnostic area. You really don't have to make huge attempts in this patient if you're very convinced that that's what you're dealing with, but it's dealing out a lot of choroid. This is not a choroidal disease. Choroidal lymphoma is a different disease. Those are multiple cell lymphomas associated with systemic disease. That's not what I'm talking about today. Although there's times that you might have a uveitis patient that you really don't know what the heck is going on, and you want to do a chorioretinal biopsy. That might be helpful for you, because lymphoma is not the only thing you're thinking about. When you do a chorioretinal biopsy in a patient with a uveitic condition, you're taking the patient somewhere between a 10 to 20% risk of PVR and total retinal detachment. To try to develop a lower risk of that, you go ahead and make sure you get the posterior hyaloid up, cauterize aggressively along the area, and then use scissors to cut in a bimanual technique that material out. You'll want to use a chandelier, so you can use both hands. And then as you're taking the specimen out of the eye, you can enlarge your sclerotomy. Unlike these neat little cannulas you're used to seeing that we do everything with, this is old school, make a great big sclerotomy so that you can get the specimen out of the eye. There's new techniques to use PCR on specimens to help you make this diagnosis of the malignant process. Mayo Labs can help you looking at for this mutation in the B cells that can be identified from small volume specimens by PCR. And T or B cell, other gene rearrangements can be identified. I'm not a genetic, very good at my genetics, but new techniques of targeted next generation sequencing can also look for mutations. And the hope is if that kind of sequencing can lead to what genetic defect is there in those B cells and more targeted immunotherapy. How do we treat primary vitreoretinal lymphoma? Well, you get to know these patients really well as a retina specialist, because you're going to give them interocular therapy. Methotrexate injected intravitreally is done, and start off with twice a week injections for 4 weeks. Then you go down to once a week, monthly, and then go down to monthly injections. So these folks get to know you really well. And methotrexate can be very helpful in sterilizing the ocular contents. When you're giving injections of methotrexate, it's important to make sure that none of the material extravasates into the subconjunctival area, because it's really toxic and you'll get a really horrible dry eye. Even with your best efforts, some patients become intolerant. Another excellent therapy is intravitreal rituximab, and that can be combined with methotrexate as well, and require you to use lower numbers and a little less extensive period of time to sterilize the eye. And interestingly, a vitrectomy can be a very good way to debulk a lot of disease. So the vitreous vitrectomy surgery to clear the vitreous sometimes can be somewhat curative for the ocular disease for quite a while. I've had patients that after the vitrectomy there's not been really any intraocular inflammation for quite a while before they had to treat the eye. External beam irradiation can be done for this disease and commonly is done. The only caveat that I'd remind you is that it can induce radiation retinopathy, and these patients do have survival rates that go out to 5 to 7 years post-diagnosis with modern therapy. So you may be having a patient get significant visual problem. And so most people who take care of primary vitreoretinal lymphoma with more regularity will try to keep that as a last line effort rather than first line. And I've had great help, my colleagues here at KU with getting the rituximab to patients, because KU's cancer program obviously has a lot of access to rituximab. And for patients with all sorts of insurances, it's hard on the outside to get a vial of rituximab so that you can inject it inside the eye at any reasonable cost to the patient. It's really challenging. It's been one of the more disappointing things in outside practice of the university is progressively it's getting harder to do things that you know how to do because you just don't have anybody to support you pharmaceutically to do what you need to get done. There's just not a formulating pharmacy that's going to get you a rituximab at a decent price that the patient can afford. And that pushes then the burden back on you guys. You can use AC taps following these patients and measure IL-10 levels, and that is those levels go back up in those patients. It can be an indication that perhaps the eye is recurring and that you need to step up therapy. Because we do want to keep the eyes free of disease to help their systemic prognosis. Systemic therapies are very aggressive in these patients. They use very high dose therapy, chemotherapies to try to get the CNS treatment of the lymphoma. And in patients that can tolerate these therapies, it can really prolong their life. And stem cell transplantation has been done in some of these patients. Whether or not stem cell is a good idea for a patient is primarily reflective of their systemic health. It's quite a therapy to get through stem cell, having watched it personally. But those patients who successfully went through stem cell therapy had a significant improvement in their median survival rate compared to those who did not. So this isn't a disease like when I started with my fellowship, that is, you make the diagnosis and the patients are all going to be dead within a year. Some of these patients who are more vital can survive quite a while, and it's imperative that retina specialists make this diagnosis so that these patients have the opportunity to have prolonged survival. The time from ocular symptoms to diagnosis can sometimes, unfortunately, be a couple of years. And there are new medications being looked at, tyrosine kinase inhibitors, to perhaps be helpful in some patients. Are there any questions?
Thank you. Very interesting case, Dr. Fox. So how often do you do the IL-10?
It's nice to get one in the patient when you're in the active stage of disease, prove that the IL-10 is elevated. And then it's helpful in clinic if you're not certain if they're recurring or not, or if you need to treat. And you can get it, send it off and see if those levels are back up.
And do you keep following them up? After you finish the course, how often do you see your patient?
I don't know if I have but at least quarterly. I mean, the patients, and they tend to be relatively symptomatic when they're recurring in the eye. They at least get a lot of new floaters, so they'll come in relatively quickly. And my limited experience, 20 years of practice, I think I've had about 5 or 6 patients, but you remember every one of them. Retired physician, oncologist. I mean, these people you really know for a long time, if they're relatively healthy to survive therapy. And there is a very good CNS oncologist at KU to share patients.
Next up, we have Dr. Swati Agarwal-Sinha, who's joining us from Children's Mercy Hospital, reviewing retinopathy of prematurity.
I thought I just want to review the current screening classification of treatment guidelines because there are some new classifications which will be coming up very shortly. So There are documentations, you know, and we spoke about CD1 or even if we have Google, it's actually blind from stage 5 developmental premature. So it's kind of sometimes easy to relate to the parents, you know, because we have no CD1. So I usually kind of always talk about him. So we all know that the distribution of blindness in children in the ROP has actually gone up. And now we are almost dealing with more than 50,000 blind children from ROP worldwide. And definitely, if you see the black area, especially in Africa, because the mortality is very high, so you don't get this too much of ROP. But all the gray areas, you know, especially in the United States, and this, we have still a low risk of blindness with the premium is very good. But all over the world, where you see the red, the risk of ROP blindness is very high because the nuclear is still not as efficient as providing a premium care to these premature infants. Pretty much the same one, which is just showing the burden and the world vision of the premature infants. And it's cycling pretty much the same. Africa, we still don't get to see much just because the mortality rate is very high. So when we see ROP through the years, I think we kind of from the from a historical perspective, 1940s and 50s were very high. So once again, there was not much ROP seen. But as we come to present, we have no mortality. We have more premature infants who are surviving, but mortality is low and ROP rates are very much higher. Even though the neonatal care is excellent compared. So this is what we call it as a fourth epidemic or epidemic premature. So what is ROP? As we kind of know that the blood vessels in the back of the eye, they start developing at 4 months of pregnancy and they completely grow out by around 40-42 weeks of pregnancy. So ROP is a disorder of the developing retinal vasculature that occurs with interruption of the forming retinal vessels in the babies who are born premature, followed by abnormal proliferation of blood vessels and fibrous tissue. So when we see the pathogenesis, as you must have seen, we kind of say the zone 1 and the zone 2 ROP. Zone 1 is the most severe ROP. When we say zone 1, these are the babies who basically have a disruption in the early phases, which is also called as vasculogenesis. And these are the babies where they have a much disorganized and expressive form of retinopathy premature. And the more common and more critical one is called as a zone 2 disease, which is basically a disruption of the normal angiogenesis, which is a budding from the existing blood vessels. So this is how we kind of divide them into phase 1, phase 2, and phase 3. Phase 1 is what is there's an arrest in the progressive vascularization of the peripheral retina, which happens between 22 to 30 weeks of the postmenstrual age. During this phase, there's a belated hyperoxia, there's a decreased VEGF level. And then there's a phase 2 where there's a retinal neovascularization that is from 31 to 44 weeks of the postmenstrual age. And it is during this phase where the baby is into hypoxia with the increased VEGF levels. So this is what actually Dr. Hickman has it. This is from her, one of her papers. So the premature birth is kind of defined from 22 weeks onwards. Basically, less than 22 weeks, the fetus does not survive. And when you go to the phase 1, which is from 22 weeks to 31 weeks of delay, this is when there is an arrest of the vasculature and the stages of the ROP develops. And then you have the phase 2 when there is a decreased oxygen and increased VEGF level. This is when the infants go into stage 3 ROP. And then it is 44 weeks onwards, which is what is called as a stage phase 3, when there's a decreased VEGF level and the neovascularization decreases. And if the infant does not get the treatment, they will progress to stage 4 or 5. And if they get a successful treatment by a laser or by any other injection, then they can definitely save their vision. So when we say the risk factors in the development of ROP, we have always talked about prematurity, overweight, and autism. These are the 3 most important risk factors which has been attributed to the development of ROP. Besides that, some of the literature has also described blood transfusion, other medications, and associated illnesses in the baby. But in the recent times, now there are a lot of articles which has been coming on both in the animal model as well as in the human models, where they're talking about, based on the phases, whether you're in the phase 1 or phase 2, other inflammatory factors, especially the inflammatory cytokinins, interleukin 1 beta, 6, TNF alpha, other cytokinins, and there's also a decrease in the growth factors, VEGF,
and omega-3 and everything. Besides, they're also talking about the choroidal degeneration, which is being increased in the phase 1 factor. So these are all the growth factors and anti-inflammatory factors, which has been now reported to be involved in the pathogenesis for the development of ROP. So the last classification, which was revised in 2005, and this is what we are currently using, we say zone 1, zone 2, and zone 3. Zone 1 is which is the most innermost circle next to the disc and the macula, which is the most severe form of ROP. Then you have the zone 2, where nasally the vessels mature up to the aura, but temporally the patient still is immature. And the zone 3 is a temporal crescent. But in the new guidelines, they're going to be adding what they also call as a posterior zone 2, which is just outside the zone 1, but inside zone 2. So there's going to be what we call it as a posterior zone 2 and an anterior zone 2. Besides that, we also classify them in the stages, which we call it as stage 0, 1, 2, 3, 4, and 5. Stage 0 is what we also use the term as an immature, where the vessels are growing, but they have not completely grown out. Stage 1, when they develop a demarcation line, you can see a white line, and you can see that there's a vascular arrest and the vessels are not moving forward. Stage 2 is when this demarcation line becomes a ridge. So the difference between 1 and 2 is not much, except that it becomes with a little volume in a ridge. So we just observe and follow these babies as closely. Stage 3 is when they develop the new vascularization along this ridge. This is what we have stage 3, and this is when we really want to treat the babies. If you fail to treat the babies, they go to stage 4, which is like a partial detachment of the retina, or a stage 5, there's a complete retinal detachment. In the developing countries, because of the poor screening guidelines, we still get to see a lot of stage 4 and stage 5. I think when I was back in India, we used to see a lot of stage 5 ROPs over there. Practically, I think every week we used to have 4 or 5 stage 5 ROPs undergoing surgery. But any kind of medical or surgical success for these patients is definitely not good. They are practically blind. Besides that, when we also say in the classification system, we also describe what we call it as a plus disease. Plus disease means that there is an increased venous dilation and arteriolar toxicity of the posterior rectal vessels. And as you can see, this is one of the standard photographs, where we call it the plus disease. And this is definitely an absolute indication for treatment. The baby has a plus disease, which means that the baby needs to be treated immediately. And then there's another area. They have also introduced what we call it as a pre-plus disease, because nowadays actually we don't get to see very commonly a plus form of the plus disease. You may still have a dilation in toxicity in stage 3, so you still can treat the baby, which is also called as a pre-plus disease, which is less than what is the plus disease. And then we also call it as an aggressive posterior ROP, which is a more aggressive form of ROP, which is mostly seen in extreme premature babies, which is very rapidly progressive. And a lot of these babies, they do not go into any stages. You can just see this vascular or vascular junction, and you can see the proliferation of the vasculature. So you have to really look out for these very, extreme premature babies to make sure you don't miss them out. So in 2018, American Academy of Pediatrics and American Academy of Ophthalmology and Strabismus, they kind of, defined the guidelines again. Although the screening criteria was still the same, in the United States, our screening criteria are infants with a birth weight of 1,500 grams, or a gestational age of 30 weeks or less, or any infant with a birth weight between 1,500 and 2,000 grams, or a gestational age of more than 30 weeks, with an unstable clinical course, which may include any cardiorespiratory support, or they have anything else which a pediatrician or neonatologist considered to be at high risk for ROP, should be screened. And as far as the timing for the first eye examination is based on the gestational age at birth. From 27 weeks onwards, any baby born, we just add 4 weeks to their age. So the first screening criteria starts at 31 weeks, and any baby born less than 27 weeks, the first screening criteria starts at 31 weeks of their post-menstrual age. So this is what we do for the examination. We basically dilate their pupils. It's not a very pleasant examination. A lot of parents really do not want to stand next to you when we are examining it, because they feel that this is like a torture for the babies. We definitely try to use some tetracaine or proparacaine and dilate the pupils as best possible, so that it's not it's kind of as less discomforting for the baby as possible. And these are the indications for the treatment. So when we treat the baby, we basically divide them into nowadays what we call it as a type 1 ROP or a type 2 ROP. Type 1 is when the disease is in zone 1, any stage where the patient has a plus disease. So plus disease is an indication for treatment, whether there's stage 1 or a stage 2, it doesn't matter, but if it's a plus disease, you need to treat the patient in zone 1. If the patient has a zone 1 on a stage 3 with or without the plus disease, so here, even if the patient does not have a plus disease, but it is a zone 1 and a stage 3, you need to treat the patient. And if the patient has a zone 2, stage 2 or 3 with plus disease, besides that, we also take into consideration what we call it as a threshold ROP, which means that if the patient has a stage 3, which is 5 clock hours, contiguous clock hours, or 8 non-contiguous clock hours, then you consider them for treatment, even if the patient does not have a plus disease. And then you have a type 2 ROP where the patient may have a zone 1 or 2, but no plus disease, or zone 2, stage 3 with no plus disease, where you can still continue to watch them. So there could be a patient with a zone 2, stage 3, 1 or 2 clock hours where there's no plus disease, so you can still continue to watch the patient because they do not have a threshold ROP or a plus disease. So our current treatment, we are still targeting, as we looked at the previous slides, we talked about phase 1 and phase 2. So at this point, we are only targeting the phase 2 retinal neovascularization. Laser has definitely always been a gold standard, and it is still considered as a gold standard. And amongst the anti-VEGF injections, I think we had a really good lecture about the anti-VEGFs. At this point, I think pretty much majority of us are using bevacizumab, which has almost an 8% recurrence of the disease. Lucentis, it has shown a little bit higher recurrence, around 45% recurrence. And aflibercept is, so these are all like these are the individual studies, these are not the clinical trials. So some of this data is not from the clinical trials. So in the Lucentis, they have done the Rainbow clinical trial, but the data has not been released right now, results have not been released. And Eylea is considered as an orphan drug for the treatment of ROP right now. So the clinical trial is still undergoing. So they are still recruiting patients for Eylea. So, but even with the Eylea, the recurrence rate has been noted to be around 13%. So definitely anti-VEGF has at this point has, since we know that it can generate accelerated regression of retinopathy of prematurity. So it has taken a primary role in the treatment of ROP. And undoubtedly, it kind of helps very well, especially in the patients with type 1 ROP where they have a zone 1 disease, because in the previous past, when we used to do the laser, the chances of untoward outcomes like retinal detachment or choroidals, and because you're doing so much of laser, used to be very high. So nowadays, now the current guidelines says that we can definitely, because it holds a great promise for the treatment of ROP, if we have a detailed consent forms and the parents understands the risks and the benefits of treating with anti-VEGFs, we should primarily consider treating with that. The only things we have to remember is that they have to be followed weekly, monitored weekly, because there has been recurrences which has been noted from the BEAT ROP clinical trial. It was somewhere around 16 weeks plus minus 4.6 weeks post-injection. And other than that, there are clinical studies which has noted the recurrences around 65 to 70 weeks of their post-menstrual age. And there also has been recurrences which has been noted as late as 2.5 and 3 years of age. These recurrences which has been noted at 2.5 and 3 years of age are usually stage 4 and 5. And the ones which are less than 1 year of age are usually stage 3. I was doing a lot of clinical studies while I was there at University of Florida, and I used to follow these patients with a monotherapy. I did put up a lot of pictures over here, but one of the things guidelines says is that you should continue to follow these babies until the vessels completely grows out. And the catch-22 is that these vessels never grows out. So I started doing this whole study where I would do them under anesthesia. I would do the frozen angiography. I used to follow this vasculature. And I definitely realized I had some pictures even until the age of 5 years from optos where I could see that the vessels have not grown out. So it is definitely a pretty much of a catch-22 situation where the guideline says that you should follow them until the vessels grow out, and the vessels definitely do not grow out. So at this point, many physicians, since the malpractice is very high, a lot of physicians, they try to do what we call it as rescue laser photocoagulation. This is what they call it as a peripheral vascular retina. And they try to do a rescue laser photocoagulation. And I think it's a very distinct variation. Some do it at 60 weeks, some at 65 weeks, some at 70 weeks. So pretty much it's a very, that is what we are doing at this time. A lot of physicians, they do the laser at certain point in their life and try to ablate this area to avoid any future complications. So just because of all the malpractice we have to deal with in this situation, it's not so easy. So I think an ROP being a blinding disease, I think there has been a lot of lawsuits in there. So if you get into a lawsuit, I think it's very difficult to come out from there. Thank you. Any questions?
Next, we have Dr. Hickman, who's going to review ophthalmic residency programs working internationally to reduce the burden of global blindness.
I'm an ophthalmologist from Lawrence, Kansas. I'm a university grad. And I'm going to be talking about a public health program that tries to get residency programs to work with each other in the United States and the UK. I do work as the medical director at International for that job. And C is one that runs the program here in the United States. So there's different models of volunteering overseas. I grew up in the town that I practice ophthalmology, so I haven't gone very far. So I really like visiting once in a while. So I used to go with the senior Dr. White to Haiti when I was a resident. And that kind of model was a week-long cataract camp. It's a super rewarding thing to do. You can really learn from your fellow doctors and also from the doctors in country. There are some criticisms of that. Some people call that medical tourism. Don't really work within the system sometimes. Some of the doctors that live in these areas say you come in, you make a bunch of complications, then you leave that they have to deal with. Sometimes people for free surgery for you to show up so they can have free surgery instead of using the doctor in that country. It really kind of limits the continuity of care. Kind of the criticism of that came a program out of the International Center for Eye Health and the London School of Hygiene and Tropical Medicine. The person that kind of developed this is Alan Foster. I'm sorry if you've heard this story before about the plane crash, but he was working in Tanzania, seeing lots of patients doing tons of surgeries, and he almost died one day on a plane crash flying back to London for Christmas. And after he recovered from the plane crash, he kind of thought it's actually him looking contemplating here, looking at the plane split in half. He was thinking about what would have happened to his work if he would have died that day. And he was pretty sure because it didn't work within that system, it would have come to a stop. And so what he developed was it's called the Vision 2020 Links program. What it is, it's easier to show you an example of kind of explaining it, but it's an organizing framework that pairs a low resource ophthalmic training institution with a high so the low resource training institution identifies their needs and they try to help each other out to develop patient care training for residents and also for ancillary staff. It exists because there's a lot of blind people in the world, and details were behind there, and some of this you've heard from me already. A lot of blind people in the world keeps on going up every time a new study comes out. And there's not very many ophthalmologists in many parts of the world. Many parts of the world, one ophthalmologist per million population. In the United States and North in Europe, there's one for about 10 to 20,000. We're talking about the number of people blind in the world. We've got new numbers out. You can see that green number on the bottom. The number of blind in the world has gone from 32 to 34 to 43 million. And visual impairment, moderate to severe visual impairment, which is 2070 to 2400, has also gone up during this time. The main causes of blindness now in 2020 had to change for several decades. Cataract and refractive error. Refractive is actually going down a little bit. Cataracts have gone up from 13.7 million in 2010 to 17 million. So bilaterally blind cataract, 17 million. Moderate to severe visual impairment is 27 to 2400. They get flipped. So lots of people with uncorrected refractive error and cataract goes up to 83 million. So 2070, that's when people have a hard time working. This is a nice map from Dr. Bastramos called the Global Inverse Care Law. Kind of leads into what we could talk about just here in a bit. But the top one shows the amount of relative blindness to the size of the country. See how Europe and America look very, very small. There's not very many blind people. In India and Africa and South were loaded up. There's lots more blind people in these countries. And the bottom one shows you where the eye healthcare workers are. So lots of ophthalmologists and optometrists in Africa, in Europe, North America, and South America. And you can see how Africa is very even hard to find on the map. Hardly any ophthalmologists there at all. Lusophone, or Portuguese-speaking Africa, there's about 1 ophthalmologist per million. Franco is about 2, and Anglo about 2 ophthalmologists. The World Health Organization really wants about 4 per million in population. So this program started in 2004 with the Right to Sight initiative. The big program is run through the International Center of Art, we said, in London. In the UK, they've been doing this for 16 years. And there are 30 links projects in the United Kingdom right now. And this is something we just started in the United States in 2018. So this guy here in the Aloha shirt, Randall Lavolio, he's the CEO of C, and he's the one that's really been very supportive of this program. You can see down here, this is the Marcia Zondervan. She's the one that really started the program in London and runs it. And C went to London a couple of years ago to learn how to do it. So how it works, it's a little dense here, but an example is a lot easier to see. C, or the International Center of Eye Health, will try to find institutions that want to be part of a link. The low resource setting hospital, we usually do a needs assessment. They form steering committees, just about 4 or 5 people in each area. They like to have the dean of the medical school and head of the ophthalmology department, and also nursing to be involved. They take the site visits. So someone from the steering committee from the United States would visit Africa, and the steering committee from Africa would visit the United States or the United Kingdom. They do a whole bunch of paperwork, memorandum of understanding, goals and objectives, and a 3-year action plan form. And then C, or International Center of Eye Health, will help find funding, and then they monitor and evaluate that. So the big benefits of this, the big one is clinical skills transfer, really patient care, surgery. Retina is also big now too. They really try to increase access to eye care for all with community focus. And another big one is information technology capability and research. So the first American Links project was with Wills Eye Hospital and the Rwandan International Institute of Ophthalmology, or RIO. So RIO expressed an interest in doing a link, as did Wills. So RIO wrote out a needs assessment of the things that they really thought they needed help with. So there were no residency training programs in Rwanda previously, so they wanted to start a residency program. So they asked Will to be part in teaching, learning how to teach residents. So that was a big push of this Links project. They also wanted to do diabetic and cataract tracking program, research development, and low vision. So they formed their steering committees. I don't know if you've ever heard Dr. Feldman. He's the Wills Center for Academic Global Ophthalmology head. He had a really hard time getting Wills to go into this program. They thought he was kind of wasting their time, but he really would show up at people's doors, kept on knocking until they bought into it eventually. So they were site visits, did a memorandum of understanding, action plan. We helped them with funding, and then they're evaluating their program now, and they're coming up to their next 3-year plan. So this is the Wills and the RIO staff doing the site visits. And so year 1 of this program, they wanted to get a document of what they should be teaching residents. So they assigned faculty members from RIO to act as mentors to the RIO residents from Wills. And really a lot of the work comes to the Wills fellow who does a academic global ophthalmology year. So he goes there for several months and teaches surgery and teaches clinic there. Year 2, they also did a document of what they wanted to teach the residents during the 2nd year. The RIO directors went to Wills Eye Hospital for curriculum delivery and plans. They held a small incision cataract surgery course. The RIO residents went to the Wills. I don't know if you've been to the Wills OCAP course. Awesome. They got to go to that. And the Wills steering committee visited RIO. And then into this last year, They had a new class of Rio residents that came in. They got an outside visit in Burundi, and they did a review for the International Center ICO exam. So this is what typically what the fellow does. He did sessions of neuro-ophthalmology, suturing course. Wills has a really good wet lab course. So they did a suturing course with them. They did a cataract outreach, taught the residents how to do blocks and how to sterile technique. Later in 2018, they did oculoplastics, taught them gonioscopy, Goldman, small incision cataract surgery and suturing. And Dr. Cropsby worked with technicians there as well. And then they did a big review session for the ICO exam, and they're very proud that all of the Rio residents passed. This is the Wills Fellow and Dr. Chico Matinge operating in Rwanda. Another link that we have is with Emory University and Addis Ababa University. Same thing, both institutions came to us, expressed interest in a project. The needs assessment done by Addis Ababa University was retinopathy of prematurity screening program and diabetic retinopathy. They really felt like they needed help with that. So they formed steering committees, and we're about ready to go to the next phase, and COVID hit. And all kinds of hopefully starting up here in the next couple of months. So the UK adds about 1 to 2 link projects a year. We're also trying to add about 1 a year here in the States. Another thing they have done is they have organizations that form links. The College of East and Central South Africa ophthalmology programs and the Royal College of Ophthalmologists have formed links, and they have diabetic retinopathy and ROP network. And I think that's all I have. Any questions?
What are you doing specifically?
I'm kind of the guy behind the scenes. Dr. Feldman was real. I went to Wills to try to convince Dr. Feldman to do this, and also with Emory. And then I kind of let C take over after that.
Very cool. They're the main organization.
Yeah, the data, it's like a lot of flights and visas, and they handle most of that. And then once the links start, it's really the two institutions that we don't have a lot of input after they start. They kind of just manage it themselves.
Yeah.
We come in once, we're paying the bills, so we come in once a year and say, what have you done and how many residents have you taught?
So the fellows are flying over there and teaching. You're not bringing the residents over to the United States. They're going over there and using whatever facility.
They do both.
They do both.
Yeah. Wills flies the Rio Rwandan residents over for their big course. Their review course, that week-long review course. But it's mainly the Wills fellow and Wills attendees that go to Rwanda.
Okay, thank you so much. Next up, we have Dr. Ravi Singh, who's going to talk about sleeved light pipe for vitrectomy surgery.
This is the first in-person meeting where I asked people in the room how they get scared. When I trained in fellowship and we would do vitrectomy, there would always be a very skilled attending sitting there to assist whenever, as a fellow, I was doing cases. They would scleral depress. So when I started practice, did not always have a skilled assistant. So that's where this came from. So it's sleeve light pipe for intraoperative scleral depression. So scleral depression, the eye is shaped like a sphere. So any retina that is interior to the equator, you need to indent the sclera to be able to see it in clinic. And we all know that things that may appear as breaks or may appear as hemorrhages, when you scleral depress, things become more clear. There's enhanced contrast. You can see that the retina is detached. You can see what looked like possibly a blood vessel or a hemorrhage is in fact a retinal break. And this is critical in surgery because in surgery, not only do you need to identify the problem, you also need to be able to see it, to treat it and manage it. And one of the must-haves for intraoperative skull depression is a skilled assistant. And I have a photo of the 4 girls who helped me with the surgery at the ASC. And the reason why the assistant has to be skilled is because the assistant needs to know exactly where to position the skull depressor on the outside surface of the eye so that it corresponds to where your retractor tip is inside the eye. And then it's a dynamic process. As the surgeon moves the retractor tip, the assistant needs to be able to move side to side, also anterior, posterior, and then they need to know how much force to use to indent the sclera with, because there's changes in intraocular pressure, so you have to adjust accordingly. And when you're working and you're doing on-call cases in the middle of the night, sometimes you'll get someone who's never done a retina case before, and they're not always available. When I started practice, I used to operate at 8 different ORs, and 4 different ORs, and it was always a challenge finding someone who knew what they were doing. So you can use specialized devices like chandelier illuminators. There are trans-illumination techniques. There are special instruments which have dual purpose. They have the inbuilt light pipe, but all these are additional costs and they're not always available. So I worked on this technique to facilitate intraoperative skull depression without a skilled assistant. And there are 2 key concepts. One is to limit the length of the light pipe that can enter the vitreous cavity. And the second is to then safely transfer the control of the light pipe to the assistant. So you accomplish this by using a 20-gauge intravenous catheter. This is readily available in all anesthesia carts. This creates the sleeve. And then you use a hemostat forceps on your vitrectomy tray. And you need an assistant, doesn't have to be skilled. And this is what it looks like. So you take the angiocatheter and you have a 25-gauge vitrectomy tip. And you cut the angiocatheter to create a sleeve in a fashion that the sleeve is 5 millimeters shorter than the light pipe shaft. And when you push the sleeve all the way over, you have the distal 5 millimeters of the light pipe exposed. So that is step 1. And you create the sleeve light pipe. Then you take the hemostat, you lock the ratchet, and you turn the hemostat, you reverse it, and you pass the light pipe through the finger ring of the hemostat, and you hand off the closed jaws of the hemostat to your assistant. And you have the assistant holding the hemostat, rest their hand comfortably on the wrist rest. And now both your hands are free. You can use the retractor with one hand, and you can self-depress with the other hand. And so this was a case with a retinal detachment where that's the technique I'm using. So I have my retractor on the inside, and you can see at 6 o'clock, so this is the top of the image here, I'm depressing, and as I'm moving in for temporal, I can move both the depressor on the outside and the retractor on the inside myself. And you can kind of see there's a little air bubble that comes up, and I can easily suck that air bubble. That shows how far interior I can get without creating any problems. So the surgeon has complete control of skull depression with this technique. It is safe. The angiocatheter or the IV catheter sleeve prevents any additional length of the light pipe from entering the eye. It can be done with a novice unskilled assistant. It is cost effective. The angiocatheter costs less than $1, and it is efficient. It barely adds a few minutes of surgical time to a procedure. And I've used it extensively for primary RD repair, for vitrectomy for RD repair. I've used it for vitreous biopsy that Dr. Fox was talking about, where I can use an aspirating syringe in one hand and vitrectomize at the same time, so I know when to aspirate. In cases with endophthalmitis, where you don't have a view to the vitreous, you can limit the length of your retractor that goes in by putting a sleeve on, so you know you're not too far back. And then in cases where there's a 3-piece IOL dislocated in the vitreous cavity, you can use a bimanual technique now to try and rescue and externalize the haptic. That's it.
Thank you. Cool. It's very cool. So you just came up with that idea or technique on your own? Just
Yeah, 8 years ago.
That's really cool.
Sometimes we use this for draining supercortical.
Yes.
Just put like a sleeve comes But I didn't think about using the cannula before. That's a good idea.
So you can just put the angiocatheter cannula, and that's what I started with, and I would hand off the light pipe. The problem with that was that then your assistant is holding on to that light pipe and really pushing and working the eye. Just getting the hemostat in there takes away, gives you redundancy, so they can't do anything to the light pipe. Plus, it moves their hand away, so you have room to negotiate all the way around.
Do you put it like underneath, like where the hemostat clamps, so she's held to sit there? I didn't see that part. How is it held by the hemostat?
It just goes through the ring of the hemostat. And
Oh, okay.
yeah. So I've submitted it to OSLI right now. Hopefully, it'll be out soon. We'll see.
So you put the sleeve on and then you put the hemostat over the sleeve.
You kind of like put it through the.
Yeah. So you you flip the hemostat around and you just pass the sleeve through the ring of the hemostat. You can use anything else to hold on to it just to support it, but a hemostat is always available on the set.
Great, thank you. Next up, we have Dr. Annie Wishna. She's going to review some eye conditions unique to women.
I'm Annie Wishna. I'm comprehensive faculty here at KU, and I have no financial disclosures. So I actually became interested in this topic. I was approached by Kim Templeton, who's an orthopedic surgeon, and she told me she had developed an interest in gender-based medicine. I wanted to know if I could put together an article on ophthalmology. There was nothing existing. I didn't really know what gender-based medicine was. It's basically the idea that the same disease process and pathology can manifest differently in men versus women. So the most commonly known example of this is that a heart attack can present differently between men and women. And the recognition of this and education of physicians and nurses and the public on this has saved countless lives over the past few decades. So the idea is this should be applied to all fields of medicine. For purposes of the talk, just for clarification of language, sex refers to biological sex, your chromosomes, your sex organs, your hormones. Gender is a social construct, it's roles and behaviors. So one of the first things I found out is that women make up 2/3 of the blind and visually impaired in the United States. And one of the reasons for this is we know cataract, glaucoma, and macular degeneration are leading causes of blindness, are more common with age. And as women live longer, there are more older people that are women, they have those conditions. Also, women have heightened inflammatory response and are more susceptible to autoimmune disease. So this impacts things like thyroid eye disease, multiple sclerosis, dry eye, and lifelong sex hormone fluctuations are thought to play a role as well. So why is autoimmune disease more common in women? Estrogens act as potent stimulators of autoimmunity. 17-beta estradiol and prolactin act as enhancers of humoral immunity, while testosterone and progesterone act as immune suppressants. So I narrowed my focus onto 4 conditions that affect the eyes that are more common in women than men. So thyroid eye disease, optic neuritis related to multiple sclerosis, dry eye, and idiopathic intracranial hypertension. So we all know that thyroid eye disease is a self-limited orbital inflammatory condition that can be sight-threatening, debilitating, and disfiguring. So risk factors include female sex, older age, and smoking, and it's much more common among females. So while the impact of sex has been studied extensively in Graves, it has not really been studied specifically in thyroid eye disease. Interestingly, so while the prevalence of thyroid eye disease is higher in females than in males, it occurs at a lower rate in females when compared to Graves' disease alone. So Graves' disease with orbitopathy is only 2-to-1, while Graves' disease without orbitopathy is 3-to-1. So there's more female components to Graves' disease than just thyroid eye disease alone. So again, thyroid eye disease being more common in women, men are actually 4 times more likely to have severe disease and are more likely to have asymmetric disease. There's no specific sex-based explanations noted, and the vast majority of studies have not found sex differences in response to treatment of Graves' disease or rates of remission. Another thought of why this is that smoking is a well-established risk factor, and men are more likely to smoke than women. However, Manji et al., they found that the more severe presentation in men persisted when controlling for smoking status. There's also some evidence that smoking carries a greater risk for women than it does for men. And gender may play a role here as well. Men are more likely to have poor compliance and poor follow-up. They also may have decreased sensitivity to their cosmetic appearance and may not seek out care as quickly as women might. So more research is needed here to the differences between the sexes and how they manifest in clinical presentation, and how that affects the optimal treatment regimen is not really known. And it's important to recognize that this is a major concern in women's health. So patients with hyperthyroidism, male sex, and absence of ophthalmopathy are associated with better quality of life when looking at patients with Graves' disease. The next topic is optic neuritis. Again, disproportionately affects young adult women. And presentation is monocular visual field defects, pain with eye movement, afferent pupillary defect, and they may or may not have disc edema. So optic neuritis is the initial clinical event in 15 to 20% of patients with MS. And MS is much more common in females, as much as 3 times more common. Since early initiation of treatment has shown to be effective in slowing the progression of MS, and with just the high index of suspicion in women is critical to help identify patients with MS early on. So again, sex-based factors have not been extensively studied. Estrogen has been shown to be neuroprotective in a variety of conditions. And in pregnancy, especially in the 3rd trimester, when estradiol levels are higher, there's been links to lower rates of relapse and delayed onset of MS. But no studies have specifically looked at the impact of estrogen on the development of optic neuritis or its impact on the future development of MS. And so going along with our theme, although less common in men, men are more likely to have worse outcomes. And so at 3 months after the onset of optic neuritis, 75% of women regain visual function versus only 25% of men. So there's clear evidence of the sex-based difference. Dry eye, we all know this well, chronic condition of the ocular surface. And women, again, are disproportionately affected, especially with increased age. And so postmenopausal women are the most likely to suffer from dry eye. And this is consistent with, there's an inflammatory etiology. So severe dry eye is more common in patients with several autoimmune conditions, but are also more common in women, including Sjogren's, lupus, rheumatoid arthritis, and thyroid eye disease. And hormones have been shown to play an important role in tear film homeostasis, and low androgen levels are consistent, or one of the most consistent associations with dry eye. So in the meibomian glands, estrogen suppress lipid production, and testosterone stimulates lipid production. Estrogen can also stimulate goblet cell production. And estrogen deficiency has been linked to postmenopausal dry eye by initiating tissue-specific apoptosis. There has been the idea of using hormones to treat dry eye, but it has not been well studied. In 2001, there was a case report of topical androgen therapy being used to successfully restore the lipid layer in the tear film, but there hasn't really been further study. And several studies have looked at the effect of hormone replacement therapy on dry eye, but there's been no effect or even worsening of symptoms. Some of this is thought to be due to difficulty in categorizing and measuring dry eye over time. Iatrogenic causes and gender-specific behaviors definitely play a role in dry eye. Cosmetics, plastic surgery, Botox, facial creams, retinoids, contact lenses, tattooed eye makeup, and BAK. So all those older women with glaucoma and cataracts are using drops of BAK. But it's an important
disease process to consider. It can interfere with the ability to read, work on a computer, or drive a car. And it's associated with higher levels of anxiety, depression, and sleep deprivation. And individuals with anxiety and depression are more likely to be symptomatic from their dry eye. There's even been some link with suicidal ideation, although that study did not control for presence of depression, and there was no direct positive relationship. So dry eye should definitely be considered and screened for in women as they age, women who are undergoing cosmetic procedures that may worsen dry eye, women on medications associated with dry eye, or women with autoimmune conditions. But on a positive note, women are more likely than men to seek care for dry eye and to use the treatments for dry eye. Our last topic is IIH, again, more common in women. And this is characterized by elevated intracranial pressure of no known etiology when all other causes have been excluded. And the typical profile is an obese woman of childbearing age. And permanent vision loss occurs in up to 25% of patients with a 1 to 2% incidence of blindness each year, as these tend to be, patients the age of the workforce and parents. This can have a really big impact on our society and our economy. There have been several proposed etiologies of IIH, but we still really don't know what causes it. Proposed etiologies include cerebral venous outflow abnormalities, increased CSF outflow resistance, increased abdominal and intracranial venous pressure due to obesity, altered sodium and water retention, abnormalities of vitamin C, and chronic inflammation. And so IIH is found almost exclusively in females of reproductive age, but there's no difference in incidence between males and females that are before puberty. So it does seem that sex hormones may play a role in the development of IIH. And again, going along our theme, women are affected in greater numbers, but men are affected more severely. So one theory posited is that, and this may be a common link between all our conditions, there may be a window of abnormal serum testosterone levels that is shared by men with androgen deficiency and women with androgen excess, in which there's an increased risk of developing IIH. Testosterone has been shown to exhibit sexually dimorphic effects on human metabolism, and differences in signaling or sensitivity to androgen receptors between the sexes or epigenetic modifications to local androgen action may also help explain this sexually dimorphic response. There are also gender-based differences play a role in healthcare seeking behavior, and men were more likely to have a shorter time between onset of symptoms and diagnosis. Or like studies of headaches, men are less likely to complain about headaches or be symptomatic from headaches. So it may be that men just aren't presenting until they are noticing vision loss, and that's why that could be also why they're more prone to vision loss if they're coming once the optic nerve damage has already occurred. So just to recap, this diagram shows our 4 disease processes, and you can see these sex-based differences have an impact on just about every structure of the eye. This table summarizes how estrogens and testosterones affect the different structures, including the ocular surface, the optic nerve, and the retina. So a lot more research needs to be done in this field to determine what's causing these sex-based differences. But I think for now, the takeaway message is we know that good vision and good health are closely intertwined. And we need to do a good job of educating not just ourselves, but our colleagues in internal medicine that women need to be screened for these disease processes and have a heightened awareness for what needs to be uniquely considered in women. These are some of my favorite women: my mom, my grandma, my aunts. So, any questions?
So which one is your mom? This one?
This one's my mom.
Oh.
Yeah, I guess I look like my aunt.
Next up, we have Dr. White, who's going to talk about the philosophy of teaching ophthalmic surgeons.
All right, well, good afternoon, everyone. I want to talk just specifically about, kind of my thoughts on cataract surgery education, sort of some of my philosophies that I've developed over the last 8-ish years of doing this, and also to take a look at the state of the art and some of the future directions that cataract surgery education appears to be moving in. A few required disclaimers. I am the chief of ophthalmology at the VA, so I do have to say that the views I'm presenting here are my own and don't necessarily reflect those of the U.S. government, the Department of Veterans Affairs, or the KCVA. I also have no financial interest in any of the products that are going to be discussed in this presentation. So just as an overview, I'll talk kind of just broadly about the history of surgical instruction. I'll talk specifically about KU and KCVA and our curriculum and our approach to cataract surgery education in particular. And then I'll speak at the end just briefly about some future directions, including surgical simulation, the possible effects of laser cataract surgery, as well as future technologies. So just to give you some idea of the historical perspective of surgical education, I mean, really since the beginning of recorded history, it's been more of an apprenticeship model where the student learns from a master, and there's really intended to be one-way flow of knowledge. The knowledge flows from the master to the student, and the quality of the surgical education is highly fragmented. And so you'll have some good masters and some not as good masters. And consequently, there's a very high degree of variability. There's not really a whole lot of standardization there. I hope Dr. Bray is listening somewhere, because I wanted to bring in just a little bit of art history here, as much for his benefit as anyone. But this is one of the most famous paintings, probably in all of medicine. This is the Gross Clinic by Thomas Eakins, which was painted in 1875. And what's interesting about this painting is that they're actually depicting surgical treatment of osteomyelitis, which in 1875, the standard treatment for that was just amputation. You saw off the leg. And so this was actually a painting of a very innovative, at that time, minimally invasive approach to treat this condition. And in spite of this being, sort of a more advanced, or, perhaps you could say optimistic view of surgical treatment, really contrasts with the dark tone of this painting. You see there's a lot of black here. You can even see the patient's mother kind of recoiling in fear in the background there. And so this was really the state of surgical education in the late 1800s. So bringing us forward, we now, specifically within ophthalmology, have had some efforts to bring some evidence-based protocols into cataract surgery education. So you have the ICO, the International Council of Ophthalmology, that's put together Oscar rubrics for a number of different surgical procedures, including cataract surgery. We also have our own ACGME that's created the milestones that those of us on the various committees here know and love. And there's a growing appreciation now that both the master and the apprentice are truly both students. And this is something that I've grown to appreciate the longer that I've taught. And certainly there are a great many things that I have shamelessly stolen from my students in terms of techniques that they've picked up from others, or things that they've learned on their own. The hope is that with evidence-based protocols, that the quality of our surgical education is going to be a little bit less variable, a little bit less dependent on where you trained and who you trained under. Because there will be greater standardization. That being said, I don't think that cookbooks, so to speak, are ever going to completely trump personality. But our hope is that we can at least kind of level the peaks and bring up the troughs a little bit. And then, continuing with our art history here, this is the Agnew Clinic, which is by the same artist, Thomas Eakins, but was painted about 15 years later. And, you know, some of the amazing things that happened in medicine in between 1875 and 1889 was the dissemination of the work of Lister. And so this really dramatically reduced the morbidity and the mortality of surgical procedures. And so you compare this painting to the prior one, the environment, the lighting is much more bright, much more optimistic. There seems to be a lot more hope here. One thing that hasn't changed though is you'll see that just like today, there's still plenty of medical students falling asleep in the back though. So some things change, some things stay the same. So I want to pivot to talking a little bit about KCVA's protocol. And our protocol, I can't honestly say that it's unique, but it's certainly different from what's done, I think, in most other parts of the country. And so for our first year residents, we begin our junior residents, our junior surgeons on the last steps of the case. So typically on their first OR day with me, they'll put in the IOL, they'll take out the viscoelastic, and they'll close the eye. And when they achieve mastery of that step, we back them up a little bit further. So I'll have them start to do a little bit of IA. And then when they're comfortable with that step, we'll start them on doing a little bit of phaco, removing some of the quadrants, cracking the nucleus. And then finally, we back them up to the point where eventually they're doing all of the case. And that process moves at a variable rate for variable residents. I mean, there are some residents that move through that process relatively quickly, others that take a little bit more time to achieve mastery and competence. On average, typical first year residents getting between 6 to 12 primary cases, meaning that they've done at least half of the case or more. Typically, they're garnering 30 to 40 assists. Our primary objectives with the first year rotation are really to gain confidence in working in the eye. In addition to that, learning the steps of surgery, but really this is all about, you know, making the OR, you know, their happy place. You know, you want this to be an enjoyable, positive experience. And that's really the big key, I think, for the first year rotation. What I've observed over the time that I've been doing this is that an early negative experience can have some really long-term repercussions in terms of shaking the residents' confidence and making them a lot more timid later on in their training. And as part of that, you know, I have a 3 strikes rule. Basically, it's that, you know, I'm going to give the resident 3 opportunities to do something at most. And if we get through their 3 strikes, then at that point, I'm going to take over. I'm going to correct whatever the issue is. But as long as it's safe to do so, I'm going to return the case to the resident at that point. And that does a few things. Number one, it prevents the resident from getting incredibly frustrated by not being able to do something. And number 2, it gives them the confidence that I'm not just going to take over and finish the case for them just because they couldn't do one step. So it gives them sort of the peace of knowing that I'm not going to steal the case from them just because they couldn't figure out how to do one thing. And I'm definitely a big subscriber of Tom Oding's philosophy, which he works up in Iowa. Many of you know him personally, that it's much better to have a resident do a part of a good case than all of a bad case. And so if it looks like things aren't moving in the right direction, you know, it's time to step in, intervene, get things back on the right course, and then move on. For the second year residents, they begin to gain a little bit more independence. And from my perspective, this is really the secret sauce of the experience. This is probably the most important in terms of forming these growing surgeons. We slowly advance the case complexity. Typically, most of our second years are performing between 30 to 60 primary cases. It's probably been a little bit less than that this past year with COVID, but we're still hitting pretty close to that. And our primary objectives with this rotation are basically mastering the normal cataract. So, you know, being able to take a patient that dilates well, is cooperative, and doesn't have a terrible red reflex, and being able to figure out how to get that cataract out. Toward the end of the rotation, especially, we will start to introduce some more advanced concepts and equipment. So this would be things like pupil expanders, toric IOLs, that sort of thing. The real key with success here is patient selection. You want to set the resident up for success by giving them cases that they can win. And so, you know, if you've got the patient with nystagmus, this is probably not the best one to send the second year's way. Or if you've got that patient that's got that, you know, 29mm eye with a, you know, really, really high brow, probably not a great second year case. The other real danger that you have to watch out for in both yourself as well as the resident is overconfidence, because I think this is really the thing that can get you both into trouble. And the way that that happens is that, you know, when you're feeding some of the second year residents the steady diet of easy cases, they can kind of get the impression that they're invincible. And they're going to be a little bit more apt to take risks and do things that they might otherwise not do. And by the same extension, you as the teacher, by watching them do these kind of easier, normal cases, can be lulled into a little bit of a false sense of security and kind of give yourself the impression that maybe the resident is seeing things that, the subtle things that you notice that they may not. And that's really what can cause issues for you in some cases. For the third year, the resident is really working toward increasing independence at that point. We start to introduce advanced techniques. And this is where we're going to start to introduce less commonly used equipment. So that would be things like snares, iris hooks, those types of things. Also introducing more special circumstances. So patients who are post-refractive surgery, patients who've had vitrectomy surgery, patients who've had trauma. This is also the stage at which most of our residents will learn how to do vertical chopping as well. And basically the key for this stage is autonomy. My goal is to train myself out of the job. And I've told several of our third year residents at the beginning of the rotation that my goal by the end is that the only thing that I'm doing is cracking jokes, basically by the end of the rotation. And really, I think a very important purpose of the third year rotation is to allow the resident to explore and figure out what's going to work best in their hands. My goal has never been to create clones. My goal has basically been to give the residents tools to show them different techniques that they can use so that they can figure out what's going to work best in their hands. And I think that we do a fairly good job of that. So I want to pivot now to talking a little bit about surgical simulation. So the traditional ways of doing this have been either through dry labs or wet labs. And I do think that there's definitely still a place for that. More recently, there's been a lot more attention that's focused on electronic simulators. And for me, most of you in the room know that I'm also a pilot. I think that there are a lot of interesting parallels between surgical education and pilot training. One of those being this sort of newer focus on simulation. So within aviation, there have been high fidelity simulators that have been in use for over 20 years now. And the Federal Aviation Administration has actually approved many of these to be used to obtain ratings. So as an example of that, I actually did about a quarter of the hours that are mandatory for an instrument rating on an FAA approved simulator. And one of the nice things about these is that these are interchangeable, so you can swap out some of the components to basically be able to simulate different types of aircraft. So you can basically, for instance, with this simulator, you can swap out the throttle column and you can change this from a Cessna 172, which is a 4-seat trainer aircraft, to basically a twin engine jet. It takes just a couple of minutes to do. These are incredibly cost effective, especially if you're operating at like an airline level. You know, you look at the cost to operate one of these simulators versus the cost to operate a 747 for an hour. The difference is orders of magnitude. One of the other significant benefits of the simulator is that it allows you to practice techniques that are either not commonly used or things that are kind of dangerous. So you can practice engine out scenarios. These can also save you a great deal of time too. So for instance, when you're doing instrument training, if you're if you miss an approach and you have to execute the missed approach,
that process of doing the missed approach and then setting yourself up to do the approach again is probably going to take between 20 minutes and half hour. Versus in a simulator, oh, you messed it up. Okay, let's start you over again. So you can do a large number of approaches in a very short period of time compared to doing it in an actual aircraft. So looking at a couple of the more common electronic simulators that are out there, the IC is the one that most of us are familiar with. And this was originally developed in Germany as a vitreoretinal simulator. The company pretty quickly realized, though, that that wasn't going to be a terribly financially feasible thing for them. And so it was subsequently modified for cataract surgery. In my opinion, the construct validity and fidelity on the IC is a little bit variable. It's a pretty good simulator for like the capsulorhexis as an example. I don't think that it's as good of a simulator, though, with regard to ultrasound and the later steps in the procedure. The Help Me See simulator is actually an M6 simulator that is still in development. It's being designed primarily for use in the developing world, and it has a pretty nice curriculum that accompanies it. Most of the engineers that helped to design this are actually folks that worked for a company called Flight Safety International that designs and operates flight simulators. So it's no surprise that the skills that they learned there transferred over pretty well to surgical simulation. And having used this simulator myself, I think that the construct validity and the fidelity on this are very high. Crafting a scleral tunnel on this simulator feels almost exactly like it does in a real human eye. So I think they did a really, really good job with this. So that being said, I would say, in my opinion, we're just kind of starting to scratch the surface of what simulation can do for medical education, surgical education, and ophthalmology in particular. I do think that we still have a significant way to go before we get to the point where aviation is, right now. That being said, with some higher fidelity simulators, I could easily see at some point in the near future where we would have a situation where we could actually have residents counting simulated cases toward their totals as a potential. And this could be a valuable situation, especially in years like now with COVID, where if you had a truly high fidelity simulator, this could in some cases substitute for actual patient care and surgeries. So another topic that's been kind of a hot one is plaques. And, what role does femtosecond laser assisted cataract surgery have in resident education? There was a recent article by Hansen et al. In JCRS that showed the outcomes were pretty similar to conventional phaco emulsification. That being said, the technology is not really universally available. I think at this point, it still remains to be seen if this is really going to catch on. There are also some questions in my mind as to whether this will be a crutch and possibly even hinder the development of manual skills for residents. Thinking a little bit about future technologies, back in 1960, nobody really would have imagined phaco emulsification, and there were very few people who were even seriously thinking about IOLs. Fast forward to now, phaco emulsification here in the United States is almost universal. That being said, phaco certainly has its disadvantages. There are the problems of endothelial cell loss, retained lens fragments, and as those of us who take trauma call have seen, this creates a permanent weak spot in the cornea. And so you've got an area that the intraocular contents can escape through, given an opportunity with a late night fall. So I think there are a lot of questions about, what will the next stage be? How can we prepare ourselves for that? My personal take on that is that, we may not always have fancy technology, but we'll always have our hands. And the skills that we teach our residents in cataract surgery are things that are probably going to carry over to whatever the next big thing is. So with that, I'd be happy to take any questions.
So is this the simulator, the EyeCon, the EyeCon simulator?
So the IC is actually not an Alcon product, nor is the Healthy C. They're both completely separate companies, and completely separate devices.
I think in fellowship, I had the chance to work on further iteration of outcome simulation system. So I tried it just the first few months in fellowship. It's harder than surgery, right? And the problem is that all my scores will go to my mentor. So I really need to score high, and that gives them more confidence in giving me stuff to do. It was amazing.
Yeah,
Great job. Thank you.
All right, good afternoon. Sorry, I'll try to go as quick as I can. We need to catch up in time, and I got to get the overall.
Sorry, I didn't introduce you, but you go.
Jason Sokol. It's no problem. Occupational biological surgery. Happy to be with you this afternoon. Sorry, I got escaped here and there during the day. Okay, so today I'm just going to give a little update on the latest trends in occupational plastic surgery at QI. It's been a weird year because of COVID. A lot of things we wanted to do kind of got pushed off, and in particular for the two things we talked about today. I have this one disclosure. I am on the advisory board for Horizon Therapeutics, which is the company that makes the Tepezza Temozolomab. So the two topics we're going to discuss today together is just the latest update with our treatments of thyroid eye disease here, and also an exciting thing of corneal neurotization that we've been doing for the past about a year and a half. So just a quick overview of ophthalmic Graves' disease. I'm going to try to go quickly, not going to go into too much detail, but you can see here obviously proptosis, inflammation with conjunctival injection, parenteral injection, liver tract, and so forth. So such as some pathogenesis review, autoantibodies react to one or more antigen shared by both the thyroid and the orbit. And once the orbital antigens are recognized, there's a cascade of events that release the cytokines. And these cytokines that stimulate many different things. You get activation of orbital fibroblasts, expansion of the orbital fat tissue, secretion of hydrophilic glycosaminoglycans, and immune attack on extraocular muscles. The pre-adipocytes go to adipocyte tissue with the TSH receptor, and this is, of course, influenced by TSH and by and so forth. And just as a review for the residents, everyone here, you get increase in the size of the muscle with sparing of the tendon. And traditionally, we think of so lazy or the inferior rectus, medial rectus, and superior rectus and lateral rectus being the order of the muscles that are typically involved. Just to be aware, it's the medial rectus that's the one that's really going to put patients at risk for compressive optic neuropathy. There's extraocular muscle disruption. We see a T-cell reaction to these extraocular muscle antigens. And then just you have different clinical findings. Again, you don't have to have them in exact order, but they're just things out there that you may see, whether it's proptosis, bilateral, liver traction, corneal exposure to diplopia neuropathy, and of course, inflammation. Just a picture of a patient who was kind of burnt out disease with proptosis and lower liver traction with exposure. A patient with more severe disease with exposure causing corneal ulceration. Typical dry eyes, cornea exposure with staining, supralimbic keratitis, and here's an example of a CT showing orbital apex crowding and optic neuropathy, which in this case is actually bilateral. Here's a traditional curve, Rundle's curve, which when we think of Graves' disease, a lot is changing, and a lot of things that thinking of it may have changed over the past year and a half. We're seeing more patients treated with Tepezza, and we're getting more of an understanding. So traditionally, we would think that Graves' disease would have inflammatory phase in non-smokers for about a year and a half. Seen this part of the curve and then kind of flatten out. Smokers maybe a little longer, up to 3 years. And our thinking with immune modulators or steroids and those kind of things was really try to get the patient early in the disease when they're active and try to slow it down, try to stop them to get into that more fibrotic phase. What we're finding, and I don't have a good slide here, that there's probably acute on chronic processes happening. So there may be people maybe having disease for 20 years who might be having episodes that we're just not realizing. And so now with this new medications out there, we're kind of seeing that a patient with that disease that we might think are stable and non-active, they may actually respond to these therapies because there's probably some type of a chronic process with these spikes with activation. Whereas we used to think that we would tell most patients that you have usually 95% of people really only have one episode of inflammatory phase, and then they kind of just stabilize. So it's kind of changing the thinking of that. So what are different treatments? Of course, patients, baseline, they're all dry. You want to lubricate them, keep them well covered so their corneas don't dry out. Immunosuppression, whether it's steroids or other steroid-sparing agents, radiation for active disease, possibly surgery, and other things as well. So immunosuppression therapy up until now, we were talking about either oral or IV steroids. Right before Tepezza came out, I was typically moving more towards IV, the IV protocol, which was infusion therapy on a weekly basis for 6 weeks and then possibly up to 12. Other agents such as cyclosporin, methotrexate, Celsep, rituximab, other anti-cytokines. In terms of surgery, surgery is a great option for either inflamed or non-inflamed patients, but we talk about the progression surgery or the decompression, strabismus surgery, and of course lid surgery as well. Here's that same patient from before, just showing post-surgical changes for decompression. You can see here, this is just a standard medial wall 4 decompression. For orbital decompression, we're using it nowadays much more than probably 20 or 30 years ago, just due to the safety of decompression surgery, but traditionally used for severe proptosis causing exposure or prior to doing muscle surgery, possibly, of course, if there's the present neuropathy or cosmesis. Surgery, like many times, does carry some risk, but for decompression purposes, we always counsel patients about the risk of developing diplopia, which is one of the worst things in Graves' disease to actually manage, and then, of course, intracranial or oral risk factors as well. So what's a new frontier? We kind of went over this last year, and it's great kind of seeing this, but the teprotumumab or Tepezza, which was the first and only FDA-approved medication for Graves' disease at this point in time. It's important to know what is the clinical activity score. And to be honest, I really didn't use this score as much until I really had to get patients approved for this therapy, because in the trials looking at patients treated with teprotumumab, they were defined as having moderate inflammatory or clinical disease in terms of inflammation. So this score kind of gets a point for each one of these symptoms, and then basically the first visit was 1 through 7. In terms of 7 points, each thing gets 1 point. If it's more than 3 in the scale of 7, that's considered moderate disease, or if you have follow-up visits, more than 4 in the scale of 10. So spontaneous orbital pain, gaze orbital pain. Sometimes you need to ask the patient, they might not tell you. Eyelid swelling, erythema of the eyelids, conjunctival injection, chemosis, inflammation of the caruncle. And it's important to know that you can just get injection just from dry eye. So you have to make sure that it's related to the grades. So you got to kind of have to think about that when you're assessing. And of course, from follow-up visits, increase in proptosis, 1 to 2 millimeters, decrease in extraocular movements with double vision, and drop in visual acuity. So the last FDA came out in the New England Journal about 1.5 years ago was the teprotumumab study that led to the FDA approval, and was basically a 2-arm study. We'll get into that one second. So in this study was a good example of translational research where investigators who had initially demonstrated a role for insulin-like growth factor 1 in the pathogenesis of thyroid eye disease that showed that any antibody to the receptor, the teprotumumab, produced a meaningful improvement in 83% of patients. And the study basically broke it down to 2 arms, one receiving placebo, one receiving the drug, an infusion every 3 weeks for a total of 8 infusions over 24 weeks. And for the most part, most patients completed their arm of the study with really not too many side effects. This is just showing the efficacy of the trial. The 2 main outcomes were really looking at reduction of proptosis, and the average was about 3 millimeters for those patients, and also improvement in double vision. So like I said before, really for me, the hardest thing to treat is the double vision, because even with the best surgeries, the patients still have issues with their motility. Even with the best strabismus following decompression, they're still going to have issues with that, which is really debilitating for these patients. Of course, vision loss would be even more debilitating, but double vision is still a problem. So double vision improvement and reduction of proptosis. The other thing was assessment of the patient's quality of life improved with the ones who were being treated, and most of the patients improved their clinical activity score compared to the placebo group. This is just an example showing one patient with placebo, one patient with the Tepezza, and you can see the reduction in proptosis, injection, and so forth, following the 24 weeks of treatment. And here's the MRI finding at the bottom here showing post-treatment that the muscles actually got smaller. So it's actually causing reduction in disease, kind of a reversal of the disease process. This slide just demonstrates that the groups were pretty much similar in terms of male, females, demographics, smokers, and so forth. Just so you may have patients who are asking about this drug, and I will point out one thing on this slide. There's nothing here about hearing loss. About 8 to 10% of patients did develop some hearing loss. They described it more as like a swimmer's ear. And then once the medication wore off, usually the half-life, I think is about 100 days, it went back to normal. I'll get into this a little bit more in a second. But the basic common side effects, muscle spasm, alopecia, nausea, fatigue, diarrhea, headache, dry skin, dyskineusia, which is basically loss of taste, amenorrhea, and so forth. Those are common things that people will have. You want to be aware of patients who might be diabetics because they can have hyperglycemia. So you need to work with their endocrinologist if you put them on this medication because it has to be followed. I think we were testing every patient at their infusions, at least for their glucose. But you should probably be following their A1C as well. If patients have a history of inflammatory bowel disease, you have to be aware of that because it can cause increase in exacerbations. Patients should not get pregnant up to 6 months until after surgery. I did mention the hearing loss. It's not a contraindication. We may start testing patients, all patients, for hearing issues, and to make sure that they're not set up or at risk for having some disease afterwards. The reason for the hearing loss is to do with the insulin growth factor ear. So the hair cells in the ear have a similar receptor as these thyroid receptors in the orbital tissue. Autoantibody activation of insulin growth factor 1 receptor drives this pathophysiology of thyroid eye disease, and it's just overly expressed, this growth factor receptor. It leads to activation of orbital fibroblasts and cytokine cascade that we mentioned earlier. And the teprotumumab binds to this growth factor receptor and just blocks the cascade, and possibly just even reverses it, but for sure halts it. And we're finding that even though initially in the study patients had this amount of disease, but just there's been many reports over the past year, and just seeing my patients as well, that even patients with chronic eye disease, they may get some improvement. Again, the three main outcomes we're looking at, obviously quality of life, there's reduction in proptosis, improvement in the double vision, and that clinical activity score, which wasn't the main outcome, did improve in all those patients. So thyroid eye disease is serious, progressive, vision-threatening disease among patients with active thyroid eye disease. Teprotumumab resulted in better outcomes with respect to proptosis, the clinical activity score, diplopia, and the quality of life. And the serious adverse events were very uncommon. Teprotumumab is the only FDA-approved drug for thyroid eye disease at this point in time. Teprotumumab is a fully immune monoclonal antibody that blocks the IGF receptor, which is a key mediator in TED. And the treatment decreases proptosis, resolves double vision. Diplopia reduces orbital pain, swelling, redness, improves the vision and appearance. It's well tolerated. It's 8 infusions. So what I mentioned earlier, and I want to talk, COVID really kind of made things difficult in terms of, number one, the drug was halted at some point in the fall when they were creating the vaccines. They stopped making many drugs. So we had a lot of patients who started therapy and who had to stop it, or only got 1 or 2 doses, or whatever it is. Some were able to finish it. Also, because of COVID, we were more likely to have patients do telemedicine visits following, just to make their lives easier, which made it hard to just follow and see how they were doing. We had 60 patients who went on to TEPEZZA. 12 of them completed it, and 4 had some interruption due to the COVID pandemic. There was a reduction of proptosis by an average of 3.1 millimeters, which was similar to the main study, and an average of 2.5 millimeters per eye in those patients who stopped their COVID, so who stopped the drug because of COVID. So they still got some benefit. And it's interesting that our smokers did not do as well. I think there were only a few of those, but they only averaged about 1.5 millimeter reduction. Most patients had over more than 6 points in the reduction in their CS score, their clinical activity score. And out of the 12 patients who had double vision, 9 of them was the double vision resolved. I wanted to mention the hearing loss. The one patient I had with hearing loss, he did have baseline hearing aids and hearing issues, but he did have a significant reduction in his hearing function. They were able to increase the sound in his hearing aids, but he did at this point in time hasn't regained to pre-treatment vision. Body aches, hair loss, a few patients reported, and 1 patient did have an infusion reaction where they had to go on hypertension. Okay, so just going on to the next topic that I wanted to discuss, the corneal neurotization, which we picked up from last year using acellular nerve allograft and porcine submucosal extracellular matrix coaptation aids, and they would learn our experience here at KU. So we're going to just quickly review the procedure and mention the 5 patients that we have. So in the introduction, there are neurotrophic keratopathies, potentially sight-threatening disease. Traditional treatment options such as ocular surface lubrication, therapeutic bandage conjunctivitis, tarsorrhaphy, amniotic membrane often fail to preserve vision. The recombinant human nerve growth factor promotes epithelial healing, but does not improve the actual corneal sensation. And corneal neurotization has demonstrated potential to improve epithelial healing, corneal sensation, and even visual acuity. There are many different techniques, and we're going to just describe one we're using here. So it's important to understand that you need to have an intact nerve if you're taking sensation from someone and bringing it somewhere else. You kind of plug you to something and bring it over to the eye. So what we've been utilizing is our supraorbital vascular V1 for sensation. So if it's intact, you can actually use the ipsilateral side, otherwise we're going contralateral. So this is just demonstrating first some of the patients that we've done with the contralateral side. There's not enough time to show a video. So the contralateral supratrochlear nerve is identified with blood dissection through a medial subbrow incision. And then the supratrochlear nerve is severed and the acellular nerve allograft is brought into the surgical field. End-to endocavitation is achieved by suturing the perineurium to the perineurium of this cadaver tissue, utilizing 1009 line suture. Porcine submucosa extracellular major coaptation aid is slid over the coaptation site, which you can kind of see right over here. And is secured by placing a single 1009 line suture through the aid and the perineurium of the allograft. The submucosa tunnel is graded with blunt dissection to the ipsilateral medial upper eyelid. When I say ipsilateral, the side that you're bringing the graft to, and the nerve graft is pulled through the tunnel, as you can see here. The nerve graft is pulled through a small incision made on the supranasal conjunctiva with the globe in infraduction and abduction. You can see it coming through here. The superior 180-degree peritomy is performed, and the nerve graft is pulled through the supranasal conjunctival incision to the conjunctival space. Make a little tunnel here. And the perineurium of the allograft is dissected off to separate the fascicles. You can start to see here it separates nicely. And distal tips are trimmed because you've been messing with it, so you want to make sure it's fresh. And then the fascicles are secure in the temporal nasal perileval sclera using a 1009 suture, and the conjunctival perineurium and skin incisions are closed. And here's just the post-operative photograph. Nerve allograft fascicles are visible in the subconjunctival space. And the corneal neovascularization center scars are unchanged because we're going to get a PK soon. And in this patient, had a lot of tarsorrhaphy. So over the past year and a half, again, because of COVID, we had some patients drop off. We had 5 total cases in about a year and a half. 2 were done pre-COVID, and they've been transplanted and doing well. And we have 3 that are in the past 6 months. So 2 were taken from the contralateral supratrochlear area, and 3 were taken from the ipsilateral. First patient who, the reason for the contralateral approach, they had a CPA tumor, so his whole entire ipsilateral side was taken out. He had no sensation there. Preoperative vision prior to nerve graft was 2060 with correction. Postoperatively was 2040 minus, and he had corneal sensation at 2 to 6 at 6 weeks. We don't have any measurements after that, but he underwent PKP and is now clear cornea thanks to Dr. Jones in 2030 vision. Another patient with a long history of the facial positive acoustic neuroma with multiple failed PKPs was hand motion, and then did nerve graft from the unilateral side or ipsilateral side, and he had PKP and phaco in his 2030s with scleral lens. Most recent patient is waiting phaco and PKP. Currently has a scar and a dense NS, but again, vision about the same, but at least according to Dr. Jones, without quoting, he said the cornea is wet and ready to go. Same thing with our next patient, also related to zoster. Slight improvement with vision, but really is waiting for phaco and PKP. And at this point, 6 weeks after surgery, we had some sensation. And our last patient is kind of we're hoping she does well, but she has a history of acanthamoeba infection, multiple failed PKPs, one of Sam's scleral keratoplasties, who had a non-healing ulcer or defect, and we opted to go forward with nerve graft from the contralateral side, and we'll see how she does when she allows us to put a tarsor in place. So just in conclusion, patients are doing very well. At this point, with our small series of doing nerve allografts, using this cadaver tissue and also the cavitation cover to cover the graft, and whether you're using ipsilateral or contralateral side. There are other options for other places to harvest and graft to. We just haven't needed to do that yet, but hopefully this is easy enough to do. The surgery itself only takes about an hour, around 15 minutes, so they do pretty well. Thank you very much. Any questions? I have the
Next, we have Dr. Michael Stiles, who's going to talk to us about filtration surgery, the old and new.
Okay, so first of all, disclosures pertinent to this talk. I've received research funds from AMO and Santon, makers of the Zen gel stent and Santon pressor flow shunt, respectively, which will be discussed in the course of the talk lecture. So talk a little bit about where we've been with filtration surgery, just briefly, kind of the newer techniques and surgeries and how this affects our indications for filtration surgery for glaucoma patients. And interject some of my own personal experiences. Tube shunt started to encroach upon filtration surgery, as far as our older techniques. They had a lot to do with the TBT study, which compared trabeculectomy versus a large Barabel tube shunt in patients who had prior cataract surgery or failed incisional glaucoma surgery, both of which are risk factors for failure for filtration surgery. The cumulative failure rate in over 5 years for trabeculectomy was almost 50%, where with tube shunt it was about 29%. Also, trabeculectomies had more of a higher complication rate early, more blood leaks, the typical things, pressure spikes that required needlings and et cetera. So tube shunt became more popularized, over the last decade. So the same group decided, well, let's look at primary surgery. It's not like patients who had prior incision surgery, but patients who need glaucoma surgery but never had any kind of procedures before. In different populations, we get a different result. So over the course of 3 years into the 5-year study, trabeculectomy produced a lower pressure, 12 versus 14 on average, about half the medication use or dependence compared to tube shunts. Also, a risk factor for failure for tube shunt in that study was lower opening pressure. So somebody in the low teens or mid-teens who has filtration surgery, they're more likely to be successful with trabeculectomy over tube in patients with no other history of surgery. There are more hypotony failures in the trabeculectomy group. Again, more, you take on a little more aggressive procedure. You do have some chronic hypotony. However, still the failure rate was less significant in the trabeculectomy group versus tube shunt. There were more early complications again with trabeculectomy compared to tube shunt, but these were typically self-limited. So the ongoing concerns with both procedures, with trabeculectomy, it's the early complications and the numerous post-op visits that are required, which in you're dealing with a population that may not be that mobile, may not be able to come to the office if they travel a long distance. That's a concern. And tube shunts, the biggest concern is real estate. Conjunctiva, there's nothing that wrecks the conjunctiva more than the big tube shunt. Also specific to tube shunts, diplopia. Again, nothing more frustrating than having a well-controlled patient. They come in, they're complaining of double vision once their tube opens up. Late erosion is specific to tube shunts and endothelial cell loss with anterior chamber replacement. That's becoming more studied and more of a concern long-term. And both do have a significant loss of best corrected visual acuity. If you look at the TBT study, in the TRAB group, there was about 28%, a loss of 2 lines or more, and the tube shunt was about 17%. Thus, we're looking for other things that might be more beneficial for our patients who have filtration surgery. The Zen 45 gel stent, the 45 refers to the internal lumen diameter. It's about 45 microns. Aquasys, the company that first developed this, first had the Zen 63, which is still being investigated, has a little bit larger diameter. But 45 did seem to be the sweet spot, avoiding hypotony complications and still producing efficacy. It's about 6 millimeters in length, and it was FDA approved in 2016. So to present the initial study, which was back in 2012, which looked at, it was a single arm study, which, and this were patients that about 70% had prior cataract surgery and about 2/3 had prior failed incisional glaucoma surgery. So a fairly high risk population for this initial study that initially looked at Aquasys, or excuse me, the Zen gel stent at that time, Aquasys shunt, in behalf of the FDA. So it produced about a 36% pressure reduction from 25 to 16 after 1 year.
And if you looked at some of the adverse events, hypotony was significant for the first week. And if you, and those of you who've done a Zen-gel stent, you can notice when you do an external approach, there is some leakage around the lumen. So depending upon the scleral thickness, you could get some excessive leakage around the, around the shunt and get some initial single-digit pressures the first few days, which can be significant, although persistent hypotony, and you never see this in a trabeculectomy study, 0%. Best corrected visual acuity loss was 10% in this high-risk population. And again, there were some concerns with needlings and more procedures that were required to ensure the success of the procedure long-term. So, and again, the FDA approved method is internal application, internal application of this shunt. However, compared to trabeculectomy, we see less success rates, not as low pressure, and more medication dependence after the procedure. So the procedure has evolved, as Dr. Alapati can substantiate that. We had a development or evolution of how we do this to try to make it better. And initially, with the ab-internal approach, the problem, although you have no conjunctival opening and no risk for blood leaks theoretically, the problem is the inconsistent delivery. Is that delivery going to be sub-tenons? Is it going to be super-tenons? Is it going to be M-tenons? And controlling that, because this ultimately affects the success rate of the procedure. Those of you who've seen like an ab-internal procedure, sometimes it curls up on itself and you have to needle it to get it unraveled within tenons. So for a while, there was an ab-external approach where you go transconjunctival, where you just skim along the conjunctival surface just over tenons and try to have this tube be the external delivery supratenons under conjunctival. However, again, you can't always control exactly where the external tip's going to be, and sometimes this has led to more leaks and actually exposures of the tube through the conjunctival. So now we've evolved to ab-external, and this is off-label, the conjunctival peritomy. And you have a more consistent delivery in that you can control, if you don't like the length inside the eye or outside the eye, you can just right there adjust it. You can make sure that it's sub-tenons, it's not raveled up in tenons, and less exposures, and most likely better efficacy. There's been some, if you look at non-randomized data, there seems to be a better pressure control with this method as opposed to the original ab-internal delivery system. Nate Ratcliffe reported a video presentation at SRS, just a retrospective case series, and found that with the open ab-external approach, better pressure reduction, less needlings, and significant reduction in the need for second surgeries to control the patient's pressure. So this seems to be the technique of choice currently in delivering this technology. You still have to make a small peritomy with the theoretical chance of some leaks, but overall, I believe, and I think most of our colleagues believe that this is the best way to go. So again, it's the preferred method. The less real estate is used. If somebody typically on this, we typically would deliver it in the supranasal quadrant. You're not as worried because of the more posterior blood about blood dysesthesia in this quadrant, which you would be concerned with the trabeculectomy. Not as concerned about, hopefully, not as concerned about long-term blebitis because of an anterior bleb. In fact, some of our colleagues around the country are actually using this inferiorly for patients who have rect conjunctiva superiorly and feel like they're not really increasing the risk of endophthalmitis as you would not do with trabeculectomy. So if it fails, you still have the superior 12 o'clock position for trabeculectomy, so you're not really burning any significant bridges by doing it this method. So probably we'll just talk just briefly about the Stent microstent. It was approved in Europe in 2012 under the name of PreserFlow, and although it's not been yet approved, it's under pre-market approval by the or pre-market approval application has been submitted, and to the FDA. It's under FDA review currently. How this differs from the Zen-gel stent, it's a little bit longer, 8.5 millimeters, but it does have a larger lumen. Less likely, you would think theoretically, be plugged up by pigment, which sometimes you see with the Zen-gel stent. It is it's placed under a conjunctival peritomy, And it is made of SIBS, which is used in the cardiology world and is found to be biologically inert, unlikely to attract fibroblasts. So you may notice a familiar name, Juan Valle. That's the brother of Dr. Valle here in town. He's in the Dominican Republic. He and his colleague in France, Dr. Riss, they have reported their 1-year data of their experience. They've found about a 50% reduction in intraocular pressure with this, which rivals trabeculectomy studies. So in 1 year, it produced about a 50% reduction in pressure from baseline. There was a randomized clinical trial here in the US, we followed the patients for 2 years, and the 1-year data is up for publication in the Blue Journal here fairly soon. And this is a randomized study comparing trabeculectomy to Sanfilippo shunt with mitomycin. So these patients, it's a cortex-based trabeculectomy, cortex-based flap for both arms, mitomycin C with mitomycin sponges was applied, and you create a track with a specifically developed blade, and then the implant is snugged into a scleral pocket, which is watertight, so there is no leakage around the lumens to prevent early hypotony, and then conjunctiva is then closed, much like an open Zen technique, pretty much. So if you look at the 1-year data, the pressure reduction was about 47% in the trabeculectomy group and about 36% for the microshunt of 1 year. There was no significant difference in medication reduction, although if you look at the medication-free patients at 1 year, there was a higher percentage in the trabeculectomy group of 84.8% versus 71.6% in the PreserFlow microshunt. So this prospective randomized study showed significant pressure reductions, significant medication reduction. However, the primary effectiveness endpoint was met by a higher percentage in trabeculectomy, 72% versus 53% in the microshunt. There was no significant difference in endothelial loss, which is always a concern when you have a tube in the front of the eye. And of course, that's just the 1 year. This again is being followed for at least 2 years to completion. And there are no reports of endophthalmitis or erosion, and no difference in surgical reoperation rate between the two groups. As far as safety, there are fewer adverse effects in the microshunt group in the first 3 months. However, there was more intervention in the microshunt group beyond 3 months for elevated pressure, whether it's adding medication, needlings, etc. Again, the reoperation rate was not significantly different between the two groups and was relatively low. So where are we now with these procedures at this point? In our practice, the Zen gel stent seems to be the filtering surgery of choice. It is ideal when patients have to travel long distances, which many of our patients do for procedures. I do tend to avoid this procedure in patients who are at high risk for if they have early hypotony. So I would not the ideal patient, somebody with an opening pressure of 40, elderly, prior history of anticoagulation, post-nephrectomy. Those are patients that you can see supracortical effusions and hemorrhages during that first week. So these are the patients to avoid. Again, most likely related to leakage around the lumen, particularly again, a higher myope to a stem sclera. That's something that you can see, and hypotony megalopathy is concerned in that symptom. Trabeculectomy is still the go-to procedure if you need a really low intraocular pressure with no or minimal medication dependence. It's my go-to procedure for a failed Zen. Again, if they can travel back and forth for the numerous post-op visits. The post-op care, again, the early complications are ongoing limitations for trabeculectomy. Tube shunt is ideal if the trab or the trab or Zen has been unsuccessful, or the patient is high risk for scarring, neovascularization, uveitis, etc. In post-op follow-up concerns are concerned for trabeculectomy, but not for this procedure as much. And certainly, for a Zen candidate, tube shunt is an option.
And, you know, if still, you look back at the primary, or excuse me, the original TBT study, something you have to keep in mind is that we always have to kind of go into with the idea that none of these procedures are going to last lifelong. Sometimes they do, but if you have a 60-year-old pseudopig who has a long, you know, good lifespan yet ahead of them, and you may not necessarily pick a tube shunt just based specifically on the TBT study, knowing that you know, these things have a natural half-life, and you only have so much conjunctiva and real estate to work with for filtering surgery. And you know, this ongoing struggle, if you look, whether you look at both, you know, turn of the century, full thickness surgery was in vogue. Turn of the 20th century. And so whether it's full thickness or trabeculectomy, trab versus tube, MIGS versus filtration surgery, trab versus, and all these things, it's that constant struggle. You know, as I tell patients, there's a risk of the underlying problem, and there's a risk of what I'm going to do to you next. And so that always has to come into play as you decide what's best for your patients. Thank you. Yes.
A patient that was in jail stent place, they got staff at the endophthalmitis. The device stay in, is it as a tendency to be a bile challenge, or what's your recommendation in that setting?
Yeah, well, you know, I know with traditional tube shunts, you just treat endophthalmitis, you don't necessarily need to take the tube out. Now, in a case like that, it's most likely to fail anyway. I think it's probably worth just going ahead and taking it out. But, you know, traditional tube shunt, that's more involved. And I did see a study in the past where they showed that as long as you treat the endophthalmitis aggressively, the tube can stay in. But I think in the case personally, I would probably take it out. But you know, it's still, again, to your point, it's still filtration surgery. You know, even though it's the rules in jail stent, bad things can happen with filtration.
So it can be the reason for, it can cause endophthalmitis, so like a patient may have endophthalmitis because of the
well, you know, I think anytime you have a filtering blood, no matter what the source, that's always a possibility. You know, you think theoretically it's going to be more posterior, less likely to have that problem. But I probably one of the devastating cases I've had with a patient who had a one-eyed patient with a traditional Arabelle tube shunt. I think everything's covered up, endophthalmitis loss vision. So it's always possible.
Is the blood usually though, do they get like blebitis, kind of some signs that the, you know, like if
Right.
the hardware or filter should have some signs of purulence or redness or something in that area?
Well, yeah, typically it's in the filtration blood area.
Right.
So yeah.
So I
And
think,
yeah.
so if it's completely white in that area, would you pull the tube?
Well, I think evidence suggests that you don't necessarily need to. No, not necessarily. As long as you treat, you got the good humors of the antibiotics circulating around in there.
Maybe someone's glasses, did somebody forget their glasses? Okay, all right. Well, next we have Dr. Eric Fry, who's going to review cataract surgery and long axial lengths. Thanks for coming all the way out here.
Oh, pretty good.
Can't close there and ignore that. Thanks for letting me up. It's nice to be here for an in-person meeting. Finally see some faces here. But I'm gonna just kind of review my approach for cataract surgery and high axial myopes. This may be basic for some, but I think even in basic talks, people can pick up some good pointers. So when we're operating on eyes with high axial myopia, what are some of the challenges? Of course, we know that biometry can be a challenge. These patients can have posterior staphylomas, which makes measurement hard. A lot of times they have retinal issues, which gives them poor fixation. So we're not exactly sure if we're measuring the right axial length. We know that our IOL power calculations have to be modified for these long eyes. So which formula is the best? Which one do you use? When we're operating on them, there's intraoperative considerations. These patients often get reverse pupillary block. They have slow scleral rigidity, which can lead to complications such as PCR. And then postoperatively, there's always a risk of retinal detachment in these long eyes, and of course, endophthalmitis. So the first thing is biometry. So we want to have accurate biometry, and the gold standard is optical, but this requires a clear media to pass through. It also requires the patient can have good fixation. So as long as we have those two, then we know that we're going to get a really accurate axial length. But if the patient can't fixate well, or they have a really dense cataract, then we have to resort to ultrasound biometry. And then, you know, we need to be aware that these patients often have a posterior staphylomas, which can result in up to a 2 millimeters inaccuracy, which can really affect our IOL power calcs. And we can determine whether they have that if we can't see back there by OCT, or excuse me, by B scan, but OCT can also pick that up if the media is clear. So the IOL power calcs, which ones do we use? So I got this from Uday Devgan's website. So if you haven't ever looked at that, cataractcoach.com is really just a great website. She's got a wealth of information as far as cataract surgery goes. But the Barrett 2, the Holiday 1 with the Wang coat modification, a lot of super formula, and the Hill RBF are the most accurate methods for calcs on these long eyes. I use the Barrett and the Hill RBF exclusively, and I have really good success with those. But there's been a lot of good papers on a lot of super formulas, so I hope to use that at some time in the future. And so when we have really long eyes, so axial lengths longer than 30 millimeters, I always aim for a fair amount of residual myopia in these eyes, so 1 to 2 diopters. So if you have a patient who's a -18 or a -20, and you bring them back to a -2, they're going to be really happy. But if you bring them back to a +1, they're going to be really unhappy. So even if you miss by a little bit at a -2, again, their vision is going to be so much better than it has been in the past that they're just going to be ecstatic. So intraoperative considerations. So these patients almost always develop a reverse pupillary block at some time during surgery. So this occurs when the iris contacts the anterior capsule for 360 degrees. The anterior chamber pressure exceeds the vitreous pressure, which causes a marked deepening in the anterior chamber. Pupil dilates, and then the patient experiences some pain. And so this is much more common in axial myopes, usually with axial length greater than 25 millimeters. It's also very common in post-vitrectomized eyes and loose zonules. So what do we do when we encounter this pupillary block during surgery? So this usually occurs after we've removed the cataract, and then we go back in for the INA. So we do that. We have a lot of flow from our INA. We enter into the eye, and the pupil dilates. The bag iris complex goes back to the optic nerve. The patient grunts, and then the way we correct that is just either raise the iris, which is what I always do, but you can also depress the anterior capsule, and then that allows fluid to equalize the pressure between the anterior and the posterior chamber. But when I know that these eyes are going to have this, like they have a long axial length, or they've already had a vitrectomy, then I want to minimize the risk of this pupillary block. So the way I do that is I lower my effective bottle height to its lowest setting, where the fluid is just barely dripping out of the instrument, and then go into the eye and raise the iris before I raise the bottle to increase the infusion pressure. But it's important to note that if we do this and there's already viscoelastic in the eye, it'll prevent the fluid from going behind the iris. So we have to remove the viscoelastic before you raise the bottle. So this first thing I show you here may blow your mind, but this doesn't have anything to do with long axial length eyes. But when I do cataract, I mean your eardrums. I know that. I think we'll be able to do that. Told myself I wasn't going to forget to mute button before I did that. You can just mute everything out, because that does here. So when I start my cataract surgery, I always make my main incision first. So I always do the a long incision where I make a little hydration pocket and then make my main incision first. So I feel like this is much easier than doing the paracentesis first. It's much easier to get your cannulas in the eye. You don't have to go hunting for the paracentesis. You can see it here, just a little stab incision for the long, and then my main incision. And then again, even if the patient's rolling their eyes up from the top of their head, it's just much easier to get the cannula in the eye to instill either your lidocaine or your viscoelastic. And then after you do that, you can come in and make your paracentesis. All right, so, sorry, technology. All right, so this is a patient who's had a vitrectomy, has silicone oil in the eye. I know that they're going to have a propensity to develop reduced pupillary block. We know that the zonules are probably going to be really loose. You can see the iris is going to be floppy because they have synechia, which I have to break here. So this, by manipulating the iris, we know that that's already going to make it floppy here. But after we remove the cataract, you can see here we go in the eye. And see, I made the mistake there. So if you notice that, it's a little bit hard to see in the video. But I went in with my flow high. So if you watch the edge of the iris, and it's not as obvious in the video, but under the microscope, it's very obvious. Everything just goes way back towards the optic nerve here. So I'll show you that one more time here. So we got the flow high. You can see that go into the eye here. And I'll watch the iris. The optic nerve just kind of almost disappear, so that I stop, tell everybody to lower the settings on there. Now you can see as I lower my effective settings, my bottle height of fluid here starts to reduce. And now it's just coming out. It's just a dribble. And now when I go back in the eye, the pressure is not near as high. So there's viscoelastic in the eye. So now I got to remove that viscoelastic to allow the fluid to be able to pass between the iris and the anterior capsule here. So I remove that, the chamber starts to shallow just a little bit. And once that chamber starts to shallow, I know that the fluid can go behind the iris. Now I raise up the iris there, we raise the bottle, and everything kind of stays where it's supposed to now. The patient doesn't develop that capsular block. So here's another case. Patient has loose zonules. He's developing capsular block during the phaco. Everything's much too deep for my comfort, so I raise the iris. Everything shallows, gets back into a much more manageable position, and so I'm able to remove the nucleus. So I go with low fluidics here. You can see that kind of iris does go back, but it kind of gently goes back. Now we're able to raise the iris up here, but after stretching the iris from the reduced pupillary block, you can see where the pupil comes down. And I'm starting to think that probably I should have used a Malyugin here, but I struggle through it. I'm able to remove all the cortex. Still a little more viscoelastic in the eye to place the lens in the eye. But again, here, when we go in with low settings, you have to remove the viscoelastic first. And then once everything starts to shallow just a little bit, then we can raise the iris and then raise the bottle. And you can see here that as that breaks, you can see how the kind of the pupil and the viscoelastic and everything start coming down there into a more manageable position. So, but what about in the real axial myopes, when eyes that are greater than 28 millimeters? So, there's not, surprisingly, there are not any great studies that show the risk of retinal detachment in really high myopes with modern cataract surgery. But we know with any cataract surgery, the risk of retinal detachment increases. And so there's been several kind of meta studies that have reviewed the risk of retinal detachment after cataract surgery, in the first 5 years or so after cataract surgery, but that's somewhere roughly in the neighborhood of 1.5%. And this, of course, is much greater than the risk in the general population of 0.08%. But they found some risk factors for this. And so young age, male patients, increased axial length, and then, of course, that posterior capsular rupture. So what are the causes of the retinal detachment? So anterior and posterior movement of the anterior vitreous could put traction on the peripheral retina. If you get a PCR and then you cause traction on the retina, of course, we all know that can lead to tears in the retina. But also syneresis and posterior vitreous detachment, which are much more common after cataract surgery. But of these four things, the two things that we can really control are anterior and posterior movement of the anterior vitreous during surgery, and of course, not breaking the posterior capsule. But in these long eyes, like I mentioned, I'm really concerned about large changes in the anterior chamber depth causing a tear in the retina. So in addition to reverse pupillary block, I'm also concerned about shallowing of the anterior chamber causing traction on the vitreous. So in these cases, in long eyes, longer than 28, I always instill viscoelastic between any instrument changes to minimize changes in volume of the anterior chamber. But in addition to that, at the very end of the case, when I remove all the instruments to avoid anterior chamber collapse, I add air to the AC at the end of the case. So show you that here. So this is a young lady who's in her 50s, has an axial length of over 29 millimeters. I've removed her cataract and cortex here. And so now what I'll do is I'll lower the bottle again and then just instill some viscoelastic in the eye before I remove the instrument. And then this stabilizes the anterior chamber so it doesn't collapse. And then at the end of the case here, as I remove the viscoelastic under low flow settings, raise the iris to prevent any reverse pupillary block. And then at the end of the case here, lower the settings, add a little bit of air to the eye. And then this prevents any collapse of the anterior chamber. So other people have advocated hydrating the wound. I think Bobby Osher talks about that. But I found that putting a little air in the eye is much more effective than just hydrating the wound before I do the, before I remove the final viscoelastic. So just another case here to show that this is a young gentleman in his 40s, axial length greater than 29 millimeters. He had a toric lens here. We can see here, before removing the instruments, instill some viscoelastic in the eye here to stabilize the anterior chamber. Rotate the toric lens in place there. One of the nice advantages with the toric lens too is sometimes when the anterior chamber collapses, that lens will kind of want to prolapse out of the bag there. So in addition to stabilizing the anterior chamber to prevent any anterior movement of the vitreous, it also really stabilizes the toric IOL there. So a little air at the end of the case there gives you a nice stable anterior chamber that allows me to hydrate the wound. Again, I like a long incision there, so I hydration pocket, pressurize the eye there. And then just remove the little air bubble there, and that gives you a nice stable anterior chamber without any unwanted collapse of the anterior chamber. So this is a quote I saw the other day from the late, great Alan Crandall, which I thought was appropriate, but he says, if you're doing the same thing in 6 months from now, you're falling behind. So hopefully you got something from that talk. Any questions?
That's great, thank you. I try to, the only probably unique thing I try to teach the residents, I was taught that way by Arsham Shabani's, always have something going into the eye when you're removing your, hydrating instrument. So I actually inject just BSS and that works pretty well.
Yeah.
Might save you some time instead of visco, so you don't have to go back and take it out, but that works pretty well too.
For sure.
It really helps with comfort also, not just,
Yeah.
Okay. So next we have Dr. Ajlan, who's gonna review some of his endoscopic vitrectomy procedures.
Thank you. Good evening, everyone. Thank you for the opportunity to present upon today. My topic is exploratory endoscopic surgery. I know I have 13 minutes, right? So you can just remind me. So here are the outlines of my talk. I'll be talking about the principles of endoscopic vitrectomy, unique properties of the endoscopes, common indications, and exploratory endoscopic vitrectomy. Dating back to 1934, Brooke al. designed an instrument. It was about like 6.5 millimeters to retrieve non-magnetic objects from inside the eye. And it used to be like a tubular instrument that they can see through inside the globe. And then a few years later, in 1978, Norris and Cleasby designed another like 1.7 diameter probe for endoscopic intraocular surgery. That was around like 13 to 14 gauge instrument. And then a few years later, in 1990, Ghoshi and Arai coupled the flexible 20 gauge video endoscopes with remote camera for real-time image visualization. So the basic principles behind endoscopy, you need like an image capturing system from the eye, inside the eye, that's a lens, the camera, and the conduit system that's transferring the image from the tissue inside the body, outside the body, and the viewing system, either like a direct visualization or a monitor screen. In general, there are two types of endoscopes. There is like gradient index lens system, which is more like a rigid system. It offers a high quality image and visualization, but it's like more bulky and afford less maneuverability, and that's limited field of view. The other system is the flexible fiber optic system. It has a smaller instrument, offers high surgical techniques and maneuverability. And now with the recent advances in technology, we're having better image quality and visual illumination. So this is the only system. This is an image of the fiber optic system. That's the only system approved by FDA in the US. There is like illuminated probes, and there's the probes with the laser pointer. So you can see the central part is the image capturing lens, and this is the illumination. And the probe has laser visuals down here. And I remember starting in training, we used to have only like the 6,000 pixel instrument because we wanted to use it in vitrectomy, so it was 23 gauge. But now we have up to 10,000 pixels. That's what we have here at KU, 23 gauge. But you can have up to 17,000 pixel image with the 19 gauge probes. We also have this here at KU. Going back to moving to the unique properties of the endoscopes, what does it offer us? We can circumvene anterior segment opacity as a retina surgeon. We can go around those opacities and go to the back of the eye. It also offers surgeons a unique viewing ability. Instead of having just like the bird view system to the fundus, you can have like a 90-degree angle and view to the anterior pathology inside the globe. You can also have a view to the very anterior pathology, like if you're looking at the ciliary body or the pars plana. I don't do those lasers, but I'm sure our colleagues here in the anterior segment, they do CPC. But that's not a PCP, right? Like what you call it, PCP. Yeah. You can tell how often I do it. So this is another view. You can see here, this is a patient from fellowship. That was like 6 years ago, where we had like, patient had 360 laser, but you can see the PVR coming from the pars plana over the laser and causing traction to the retinal tissue. If you scleral depress, you may notice everything attached, but when you're not distorting the tissue, you can see that you can have a perception on how like tissue are arranged and how is it pulling on the retina. Also with endoscopic illumination, you are using coaxial illumination compared to dissociated illumination. What does it mean? It means that if we're using the microscope as a retinal normal surgery, you have the light probe to the side and you're viewing from the biome system here. So that's dissociated illumination. With the endoscope, the camera is over here and it's coaxial where the light is going through to the tissue and coming back. So in this experiment, does that make a difference or not? So he got a piece of prostate tape to resemble vitreous tissue. And that's a piece of prostate tape. They used dissociated illumination, and this is how it looked like. But with endoscopic visualization, some tissue may appear more prominent, so it gives you more clues during surgery. Moving forward to the common indications, the common examples. When do I need to use endoscopic vitrectomy for my patients? If there is an anterior segment opacity or temporary keratoprosthesis, if there is difficult to access area or disease and complex retinal detachment. Here's an example of a patient. This is one of our patients here at KU. She had endophthalmitis in that eye, a failed graft, and then she developed a TRD later. So we're going with the endoscope. I'm removing, for the sake of time, I'm removing that debris and the vitreous tissue. And we're proceeding with the membrane pale all endoscopically, and then ended up with silicone oil. I'm just trying to make time for other videos. This is another patient, also like 6 years ago, I think. PKP, endophthalmitis, and we were doing partial vitrectomy for, this is not playing. So for the endophthalmitis, so there was a membrane over the nerve over here, so we peeled all of that. This is another patient, 2015. He had a chronic TRD and diabetes. So we're peeling the membranes. We have a good view to the posterior segment. But when we're looking at the far periphery, he has like PVR going through and covering the ciliary bodies and having epiciliary membranes, which were causing a shallow ciliary body detachment. So we had to use the endoscope, go really anteriorly, peel all the scar tissue anteriorly so the ciliary body can go back and the hypotony get relaxed. We also ended up doing like 360 retinectomy. This is actually one of my mentors in 2015. And then there was like subretinal PVR, so we ended up peeling that off, putting the retina back in place, 360 laser. That eye had a 24, and we can see the ciliary body now, everything was peeled off. 2400 vision, but IOP much better than before surgery. And then what are we doing here at KU? Why are we doing exploratory endoscopy? What's the role of it? Usually, if I found this so useful in our patients, especially in patients who have a history of retinal detachment and have silicone oil in the eye. So many times I would have cases, especially from our cornea service, they will come and say, this patient needs a cornea transplant and he has oil. What do you think? Do you think we should pick the oil or not? So I will go and have a look. But even on the B scan, the retina may look attached or may appear attached, but I don't know if it's all scarred out. We don't have no medical records. The accident happened like 10 years ago and we don't know what's going on. So it can be useful exploratory endoscopy for patients who have to evaluate the visual potential for those patients. I may enable retinal pathology repair. It's limited though, right? If you need to use bimanual approach, just go to the cornea team and ask for temporary keratoprosthesis. I remember a few cases I will go to Dr. Goins or Dr. Sutphin. I can't do this case, doctor. I need both hands. So it has some limitation, but we have some examples here. Look, this is a patient, I think in his 40s. He had a previous open globe, came to us like this, and he had a history of eye surgery with oil. He needed a cornea transplant, but we don't know how his retina looked like. So now we're looking back and we can see that he has a choroidal rupture or macular scar, but all the retina is attached. So that was a really nice case. So I just added more laser to the periphery where areas were not lasered, made sure that 360-degree laser was complete. And then ended up with like silicone oil removal and air fluid exchange. And that was a wonderful case. I hope every case are like this. And then I send him, go back in a month to the cornea people. They will do a cornea transplant and we should be fine. Another patient, this was another patient, I think in his 50s. This is the good eye. Stephen Johnson, symplepharon. The other eye, she lost it now because she had endophthalmitis. You can see I was trying to find even the limbus. This is a patient, Dr. Sutphin. So I go in with the endoscope. She wanted the oil out because she wants a cornea transplant because she wants to see again. So I go in and I see she has like, this is all retinectomy. The hair macula is like, this is what's left over there. So I'm going in, I see some PVR anteriorly with traction with the anterior segment, and this is all under oil. So but it was a mature PVR and 360 laser was there. So I ended up like cutting over here, cutting what's like traction bands from the anterior segments and filling up more laser. I was using here the endoscope laser and filling up the 360 laser. We see here emulsified silicone oil, and then airflow, like oil removal, multiple air fluid exchange. Pressure was maintained. And go back to Korean. So sorry, Dr. but it helped, right? If I ended up removing the oil in those patients and she has a transplant, you never know what will happen. What if they need the oil? This is another patient where this is another patient who came to us from outside. He had a remote history of eye injury with silicone oil. He doesn't know what was going on, but now he needs another cornea transplant. And the question is, can we remove the oil? I do a B scan, he's moving, it's hard. You know, sometimes you do the B scan, you're not sure. So I go with the endoscope, I'm looking here, macula doesn't look right. Then I'll go inferior, this is like a large subretinal traction band. So he is detached inferior. It's a shallow detachment. So this patient, I can, like, if I remove the oil, he will detach again, and he will lose whatever he had. So we ended up doing, removing them traction bands from under the retina. We did inferior network retinotomy and keep peeling the scar tissue, added more laser. There's a lot of traction bands. And some of them were larger. I couldn't even remove them with the forceps. I had to use my detractor to remove it. Like this one, this is too big. Didn't come with the trocar cannula. And then remove the remaining one. And the eye is like a globe, so I'm limited with my view. My view is what you see. This is what I see during surgery. So I have to make sure I'm not pulling on the other side and harming the retinal wall on the side, right?
How can you do bimanually though if you have your like how do you hold and cut if you have
one hand? So one hand the camera and light, and I just struggle and just live through it. But I had oil helping me, right? So oil is holding the tissue in place. And this is his corneas.
Maybe you could do something like Dr. Ravi Singh.
I saw it. I was like, maybe.
It's coming. 3 incisions.
That's a great idea. Yeah. You'll get the reason to hold the camera. But this is what we're doing here at KU, and it's a great. We have a great team, and we're lucky we have all who supporting system. So in this talk, we went over the principles of endoscopy, unique properties, common indication, and the role of exploratory endoscopic perspective. Thank you, everyone.
Yeah. Just kind of expanding on that, though, I mean, when you look at the general surgery world, it's fairly common practice for endoscopic cases or laparoscopic cases to have 2 surgeons, where you've got one guy that's running the camera and one guy that's actually doing aesthetic. Do you think that there'd be a role for that, either having a resident run the camera and while you're operating, or even the possibility of having like a robot possibly operating the camera or being able to control the fiber optic with your foot pedal?
So that's a great idea. So what I imagine in my imagination over the last 2 years, I hope I come up with a system where I just put the camera inside the eye and control it with my foot pedal. I'm trying to figure out the logistics, how to get someone to make it. but having someone to hold the industry, the camera, that's a great idea. It's not very, like there's not much money for the company to come up with a system. They build more for anterior segment doing glaucoma lasers. So they said like, we're not taking much for your retina surgery to make a new system. So that's what they don't bother with. So hopefully.
Okay, last but not least, we have Dr. Warren, who's going to give us an ABO update.
First of all, thank you, Neeti and Mary, for allowing me to come and talk today. I know you guys did things. I know Dr. Ajlan talked and gave my place, and I'm really appreciative to come here. University of Kansas is actually developing quite the legacy of ABO commitment with Dr. Sutphin and Dr. Goings, as well as Dr. Champion, who's one of our newer volunteers. We very much appreciate your contribution to the board. This is really important because our primary stakeholders, number one, obviously is the public, but number two is you all sitting in this room here. Much of what the board does is really geared towards making sure you are qualified and feel really good about your ability to provide that care for the public. My financial disclosure, I do have I serve as a consultant for Allergan, but I will not be discussing obviously any off-label use of medication or devices here. So what about the mission of the board and its purpose? Well, it really, ophthalmology, we're very fortunate. We've had very many firsts, and we were the first profession of group of physicians to really get together to unite around a common goal, that is to set a standard that all of our practicing doctors would have expertise in both knowledge, skills, and the experience to provide to the public good care. So the nation's first board certified doctors were tested and recognized following the American Academy of Ophthalmology meeting in 1916. Actually, this Dr. Mainster and I are back in the back there. But in the early days, this testing process was very long. It involved as many as 4 parts. There was a written examination, also an oral exam, followed by a clinical laboratory examination. And finally, something that is really likely to occur in some form or fashion today, there was a review of the patient's case logs were submitted so that you could actually look at outcomes. And that's really where it's moving today, to move towards being able to see what type of care you really are providing for your patients today. So we're not there yet, but I think that's ultimately going to be a goal. So the examination process is one where you are initially to demonstrate knowledge, and that begins with the written qualifying examination. This is a 250 multiple choice computer-based test. It is focused on basic science and your clinical knowledge. It attempts to identify your gaps in knowledge and identifies it on the content outline. So it's really divided by the BCSC. It's really very nice now when during my training, you were not eligible to sit for the written examination until 1 year following your completion of accredited residency. Now that process has moved forward so that a candidate can now take this test within 6 months of graduation, which really gets you to the certification level at a much quicker time. And much of that input came from feedback from candidates to help them move forward in the process. And this really showcases your knowledge and that you've accumulated during your residency training period. You can see what the pathways are. So one thing that the board has really attempted to do, because the oral examination and the written examination, that part is somewhat mystified. We've really tried to have the candidates understand what the testing will be like and what the expectation is about the test itself. So this is a sample question: which of the following medications may be associated with the development of crystalline retinopathy? And of course, we know the answer here is tamoxifen. So this is really the format by which the test is given. However, for the candidates, since most of them are just from their residency, the written qualifying examination really focuses on the basic science knowledge that you learned and was stressed during your residency period. So for any residents who are finishing their training and have recently graduated, you can still register for this upcoming written qualifying examination. So all of this residents who are graduating now, you will be able to take your examination this year, October 9th, again, which is a very new thing for the board. So we're very happy that we can offer that test much earlier. So now part 2 of the examination is really when you show your work, you show your fund of knowledge, you show your ability to apply that information to the written qualifying examination that you've learned. I remember very vividly last year, March 9th, I was actually at a medical school alumni association meeting, which I'm a member of the board there. And we had an emergency phone call regarding the oral examination, because obviously in the height of the pandemic, the oral exam was to be given late to mid-March. And we met as a board and decided that we were going to cancel that examination. We were the first board to do so at much consternation. You can believe that candidates were calling, the phones ringing like crazy. People had committed a considerable amount of time and money and investment into taking this examination. All of a sudden, it was cut off. So, but really pretty soon after that, training institutions instituted restrictions across the board. So it wasn't just us, it was all of medicine was really brought to a screeching halt. And the question, of course, at that time was, can't you guys do this online? Well, we had never done it. That had never been the format that had ever been tried before. So I must say, and Dr. Going and Dr. Sutphin can attest, the staff at the ABO is amazing. I mean, they are incredible. The validity that they and expertise and science they put in developing these tests is unbelievable. And so within a 3-month span, we were really able to develop a test that we thought was both valid and psychometrically accurate for the candidate. So we converted it to an online examination. We also did something that was a little bit different than before. So previously the exam was a one-on-one examination where the candidate and the examiner were in a single room, and then they went to several different rooms to cover the 3 sections that are covered. But what we did was we added a second examiner to the same room. So now, and that examiner actually grades every question. So now instead of having 42 data points, now there are 84 data points. So we have a much better assessment of what the candidate's true performance is on that test. And so it really increased our reliability and enhanced our quality control. So the oral examination really goes a step beyond the written. Now we're asking you to apply that knowledge that you have to a clinical scenario. So show your work means that you now get to explain, one, how you got the diagnosis and what you think the appropriate patient management plan should be. Again, to demystify, we're not going to ask you any esoteric. These are real questions that we want you to have some idea about your working knowledge of a differential diagnosis, how to work through that, your working knowledge of a patient management plan, how to work through that, and ethical questions that come along with that as well. So we really want to make sure the candidates are doing very good. We really, it's so funny, once you give these exams enough, you can tell us the candidates who come in who have had a review course. And really the ABO discourages that because you really get sidetracked. You know, if I'm showing you a picture of a tumor, I'm not really so concerned about what that patient's blepharitis may be if I'm showing you a melanoma. But yet the candidates will run me through that whole thing before. So we really want them to know that if you've done your work with the BSCS and looked at the samples available on the ABO website, you would really be more than prepared to do this. So there's a candidate manual, and now we actually have a concierge service where candidates can talk with the folks at the academy, give them information about how to best prepare for it. So we really want to and have listened to our stakeholders in helping us to develop a test that is much more feasible for the candidates. So it's like this now. It's all done by Zoom. There's a camera and an audio. Initially, the room is screened with a 360-degree view of your camera so that we can see that the candidate doesn't have anything in their work area. Then you walk through data acquisition. Different here, instead of there being one examiner, there's usually 2. So there are 2 examiners for every candidate. And what the candidates really verbalized very well is it was much more comforting to do it in their own setting, that it made it less anxiety provoking. You know, if you walk in the room and there's Dr. Sutphin, he's a corneal specialist, he's going to ask you about cornea. It's kind of overwhelming. At least if he's going to ask me about cornea, I can be in the confines of my own home, at least feeling a little more comfortable about my environment instead of one that's a little more, intimidating. Yeah, no question. So in these cases are usually accompanied by 1 or more photographs and or video, so it allows the candidate to walk through what are the salient points of this exam and give a good answer. So the oral is pass-fail only, and now it's really weighted on 42 cases total. So there's 84 data points on a given candidate. That's given over a 3-hour testing period. We can see the pass rate is pretty similar for all and first-time examiners. And it kind of fluctuates depending on the standard setting that we use. We throw out questions that are ambiguous or that are not scored well. And again, there's a tremendous amount of science that goes into this test question. So they are really very fair and accurate. So this also, for those who pass a written qualifying examination, that timeline is speeded up more. Again, it was a year for me following my written examination, and then another year for me following that for me to take the oral examination. And that timeline has really been closed. So again, people in fellowship programs, it makes it more convenient for them to get the exam out of the way. So the most important part is that this is not where this stops, because it's really very important that you are qualified and you remain appropriate in your care for the rest of your career. Many of you may not know this, but all commercial pilots, they take tests. They are qualified every 6 months. So they go through this process. We're happy that they do, because you want to feel pretty confident in the care they're providing you. We're not going to go to every 6 months, obviously, but you really want to feel that the ophthalmologist who is providing you care is confident in what they're doing. And this is a reason for recertification, which began after the 1992 certification examination. And this process is one that involves many things. So you must maintain an unrestricted license in whatever state you have license privileges. You have to do continuing medical education, self-assessment. You need to do 50 credits for every 2 years of practice, and 16 credits should be those that you did on your own or self-assessment. Patient safety is important that you read some patient safety articles. And we were very good in developing a quarterly question method by which you can be tested and get immediate feedback on what you're doing. You must pass at least 5 out of the 10 years that they are available to you. And then finally, there must be an improvement in medical practice activity. And there's some menus that allow you to choose between those activities, and they must occur over your 10 years of your recertification process. So what we know is the problem is that knowledge declines over time. And as you move farther away from your training period, that gap is broadened because now we have people like Dr. Ajlan who's doing endoscopic surgery. And so that's something that you need to know about. Or if it's been 25 years since you trained, anti-VEGF therapy wasn't available 25 years ago. So you really need to know about that. So that becomes an important part of the continuing education. So it is important to have a longitudinal assessment strategy, and so that it can power new learning and promote knowledge retention so that you stay up to date in the treatment modalities that you have available to offer your patient. Quarterly questions is a hybrid learning and testing methodology. You really don't have to study. These are questions that should be commonplace, and it's divided into several sections. For example, there's core competencies, there's comprehensive ophthalmology, there's vitreoretinal disease, and we're looking at developing more of those. In our recent board meeting, we talked about maybe segmenting out medical retina as a subspecialty area where we would do quarterly questions as well. And the topic choices are there, as we talk about here. And the other thing too is it allows you access to free articles. So you don't have to necessarily have a subscription to these articles. You can get those articles accessed through these quarterly questions and be able to claim CME credit for it as well. So this is probably the cheapest CME credits that you can get, particularly when we're providing the articles for you, and they're on the full text article. So this has really been a very good program. While the lifetime certificate holders do not have to participate in this program, and we really strongly encourage them to because there will and can be gaps in their knowledge. We don't grade their test. They just take it for educational purposes if they wish to, and we're trying to encourage them to do that. You can see that the success rate for participants is very high. 99% of participants met this passing standard. And interestingly, they all thought that it was a great activity. 85% said it helped them improve their care. 93% said they learned something that was useful to their practice. And 98% said they would in fact recommend this to one of their ophthalmic colleagues. So we really feel like this has been a significant step forward in this process. You can, as far as improvement in medical practice, which is the last leg of your continuing certification process, there are quarterly articles that you can use as well to satisfy that. There are American Academy courses that you can do online that will also satisfy that process. You can submit an improvement project that you designed yourself. For example, one of the applicants was looking at timing to anesthesia for intravitreal injections and pain scores. So really ideas about how they can reduce pain on a patient who's getting multiple injections. All of these things are really looking at improving how you are practicing medicine. And then finally, there's a portfolio program that institutions themselves are organizing where you can become part of a multi-specialty improvement initiative. And we're beginning to develop that in more detail now. So again, you can claim CME credits for this continuing certification. You can use those CME credits for recertification in your state licensure requirement. And you can get these, AMA will charge you for this, but you know, that's we don't have any control of the AMA. So in conclusion, the idea of the academy is with you, the board is with your input to promote professionalism and self-regulation. We're very privileged in that we're able to practice and yet we regulate ourselves. So this is our ability of our profession to police ourselves to make sure that we're providing the best and highest level of care to the patients, which is really who we serve. For me, I was certified in '94, so I just missed it because I got lapped. I would have been finished in '93, but I got lapped. I began examining in '99. I became a content writer and reviewer back in 2014 and began to serve as the director in 2020. Among all of my professional accomplishments, I would say this is probably the pinnacle. I really feel like this gives me the greatest opportunity to get back to the profession that's been so wonderful to me. And I'm very happy to see that many of the faculty here continue to participate. And we really want you to feel good about your certificate and what it means, and for you to continue to develop so that we can know we're giving the public a product that is a worthwhile one. Thank you all for the opportunity to come here today. It's a privilege to talk to you guys, and thanks.
Do you think the oral boards will remain online?
I think so. Yeah, I'm positive the response that we've received from the candidates has been just tremendous. They all like it. They feel like it's allowed them to do so. We've had candidates at a board who, one was in Beirut, one was in London, yet they could still take their board examination at the same time everybody else did. The clock was different for them, obviously, but access to the test is much easier. So I do think it will stay.
Is there a higher pass rate this year, like doing it virtually, or it didn't affect?
Well, the first series, so we did one pilot and 3 exams last year. We tested close to 700 candidates, which is what we started with, which is a big number. It was quite busy. And this year we've had 1 session so far. The scores last year were a little bit lower. And as part of, because it was a pilot program, an attempt to be fair, we gave those who failed another chance at taking an examination again because it was a pilot. And so, but I do think it will stay virtual. But I think the pass rate
a lot by being able to do it from home.
Yeah, I think the pass rate for the most recent exam was back up to higher. Yeah.
As an examiner in the near future, I appreciate that. Cut down on travel costs. Cut down on
Oh yeah. A bunch of costs, that's right. And be surprised, these test questions are pretty expensive. We have to bring in experts to help us to design the questions. There's cost to bring them in. And so that money can be better used to enhance other programs that we think would be better for our candidates.
Well, thank you. I wanted to thank everyone for coming today. It was nice to be together. Reminder, this CME credit, you can Deb sent out an email with a link, or you can go to our website. It would minimize questions for her by looking at the website. That's helpful. Thank you. Max.
Good. Nice to meet you in person. I agree. Yeah. Thank you. Yeah.